Hi, and welcome to the Myofascial Release Seminar. My name is Teresa Schmidt, and in my background as a physical therapist, board certified in orthopedic physical therapy, and a licensed massage therapist, I've incorporated a number of myofascial techniques into my practice, which I find bring about the greatest functional outcomes for my patients. And in putting together this seminar, I hope you too will be able to use your hands in a beautiful proprioceptive sense and use these techniques to get the same wonderful functional outcomes for your patients as well. Let's take a look at the history of myofascial release. Most people associate myofascial work with John Barnes, who's one of my primary instructors, and he's fabulous. I highly recommend his seminars if you have the opportunity to take them. Some of the background also comes from Upledger Institute, New York College of Osteopathic Medicine, and New York College of Holistic Health Education. So this is a compendium of several of those techniques, somewhat modified to meet the needs of your own patients. Manual therapy goes back about 5,000 years in terms of documentation to the period of the Yellow Emperor in China, which is about 5,000 years ago. They actually have uncovered pictures, illustrations on the walls of people using physical manipulations such as myofascial type techniques and manipulations to achieve results in the human body. This technique has now evolved into what we call our manual therapy group of techniques, such as soft tissue mobilization, myofascial release, joint mobilization, to name a few. With today's techniques, we'll be using the highest level technology we have, which is right here in your own hands. I think hands are great because they're always with you. You can use them to both assess and treat a patient simultaneously, and in that regard, it saves you tremendous time. In terms of billing for myofascial release, if you're actually interested in getting paid to use these techniques, I recommend the CPT code 97140, which is the CMS code for manual therapy. To understand how to work with the fascia, we need a little background on the anatomy of the fascia and the connective tissue. Fascia is actually one of four main types of tissues in the body. We have nerve, muscle, epithelium, and connective tissue. The connective tissue, or fascia, is actually the most pervasive tissue in the body. It compartmentalizes and surrounds all of the other structures in the body, from the macroscopic right down to the cellular level. So there's nothing in the body that escapes the influence of fascia. Let's take a look at what fascia does functionally. One of the functions of the fascia is to maintain our posture. If you think about it, and looking at what other people over time, aren't we all getting a little ahead of ourselves? The common forward head posture, protracted shoulders, kyphotic thorax. That's simply an adaptive positioning of the fascia, shortening in the muscles that create that position. You can easily look at someone's posture and decide where are they hiding their tension in the body. Do they walk with one shoulder a little higher than another? Maybe their head stays tilted to one side. If you think to yourself, what muscles do that? What muscles function to perform right lateral flexion or scapular elevation? Look at those muscles, the scalenes, the sternocleidomastoid, levator scapula, upper traps, for example. Then you can explore those muscles by palpation and motion testing of that body part to determine, is there a fascial restriction in that region? And then we can move forward with using our techniques to reduce the restriction. Fascia also supports your blood vessels. If you think about the blood vessels as being tubes of fascia, simply with liquid flowing through them, those tubes can become restricted by tightening in the fascia. If you've ever treated someone with thoracic outlet syndrome, you would have a clear idea of exactly how tight the fascia can become, impinging on nerves and blood vessels as a result. If you've ever treated sciatica or carpal tunnel syndrome, you're very well aware of the fascial compartment syndromes that are caused by restrictions, as well as by the nerve compressions caused by tight fascia. We can then use these techniques to help to reduce some of those restrictions. Most of us are movement practitioners of one kind or another, and thereby we're very interested in how muscles work. Most of us have studied kinesiology, looking at how fascia defines muscle motion. Let's take a closer look at our biomechanics. Consider the biomechanics of muscle. If you've ever studied kinesiology, you understand that muscles have to maintain a certain length-tension relationship in order to function with force. Muscle contraction needs to have a certain amount of force to be effective functionally. If a muscle is positioned in such a way that there are fascial restrictions causing shortening of the muscle, hypershortening, you have what's called active insufficiency. Think of the actin and myosin filaments that need to overlap when someone has muscle contraction. If the actin and myosin are too close together, we have an active insufficiency whereby the muscle will not contract with force. Conversely, if you have a muscle at its longest length or past its resting length, it might not contract with great force either because the actin and myosin in a hyperlengthened muscle will be too far apart. Thereby, muscles have to be just at the right length, usually mid-range or slightly longer than mid-range, in order to get a good forceful contraction. With our myofascial restrictions, we'll take that muscle that's shortened with active insufficiency and create lengthening, thereby influencing the strength or the length-tension relationship of muscles. I invite you to test on your patients before and after using some myofascial release. You'll be happily surprised to see that it can influence strength as well by altering the biomechanics across the joint. Fascia also aids your circulation. It influences cell metabolism. If you think about the fascia itself, it creates the interstitial spaces where your fluid exchange occurs. Waste products coming out, nutrients, oxygen for healing and rebuilding tissue coming in. If we impair that process by restricting the movement of the fascia, we then create compartment syndromes, impaired circulation, and erythema. Myofascial release techniques can be used to relieve all of those conditions, especially if we catch those conditions early on. Fascia is very adaptable as well. In terms of mechanical stress, research has shown that fascia can withstand tensile pressure or place tensile pressure of 2,000 pounds per square inch on sensitive structures. So it is critical that we get in with our myofascial release as soon as possible to reduce these developing restrictions. Fascia is also intimately involved with the healing process of the body. The fascia is continuously rebuilding and restructuring itself according to the lines of stress that are imposed on the body, whether it be from our daily activities, our posture, or outside influences and insults to the body such as accidents, work injuries, and so forth. Let's take a look at how the fascia is built. This fascia is primarily involved in depositing the collagen to heal the body after an injury. Let's take a look at the composition of the fascia. Fascia has certain connective tissue proteins within it, collagen and elastin, that need to be maintained in a certain balance in order for the fascia to be freely mobile. Collagen is a thick, dense connective tissue protein that has very poor resiliency, although it gives tensile strength to the fascia. It prevents the fascia from being torn apart. There's elastin, which, as the name implies, gives an elasticity, a flexibility to the fascia that allows us to have that motion to lengthen and then rebound back into our normal range of motion. When we lose the normal balance of the collagen and elastin, sometimes as in accidents, adhesions, post-surgical scarring, poor postures over time, developing contractures, there is too much collagen deposited in the fascia, thereby making it very dense, thick, and difficult to move. So when you get in and start palpating the tissues and you feel those areas of rigidity, those areas that have no give, that is likely an area where there's extra collagen deposition. And during the healing and maturation phase, the collagen may be haphazardly arranged. And as such, it doesn't move freely. Providing just the right amount of stress with our myofascial stretching will allow that collagen to realign in a very functional way and allow normal movement to be regained. So remember, we need that balance of our fascial proteins. Now, all of those proteins are floating around in a big bowl of jello called ground substance. Ground substance is a gelatinous matrix that maintains a critical interfiber distance between the collagen and elastin proteins. If you don't have enough of this gel substance, such as in dehydration, those proteins bump into each other, creating too much internal friction. And if any of you have ever thought of getting old, you think about what you feel like when you first get out of a chair after sitting for a long period of time. You feel stiff, there's noise in the joints, it's difficult to move. That's because as part of the normal aging process, we lose some of the components of the fascia that actually bind water to the tissue. Our proteoglycans, our glycosaminoglycans, and hyaluronic acid. So I like to tell especially my geriatric patients, drink plenty of water to keep the fascia hydrated, keep it plump and juicy. Also in the fascia, you have a cellular matrix that involves immune system cells, cells that mediate the inflammatory response. We are influencing these cells every time we're doing myofascial release. You can see the macrophages, the mast cells, the histiocytes floating about in the fascia. And when doing fascial release, some of these cells will start to secrete histamine, creating an erythema response. You'll see as you look at the tissue vasodilation, and that occurs cross-culturally. So feel for the heat change in the tissue. As blood starts to come to the surface, it brings in heat from the core, thereby warming the tissues. Ready for biomechanics? I know it's not an easy subject, but let's do a little experiment. You can do this right at home in your own chair. Break out a finger. Let's see what happens when you stress the fascia. We're going to apply pressure using the same amount of force each time. And I'd like you to notice what it feels like. Take a finger and poke yourself in the front of the shoulder several times with the same amount of force. Okay? Ready? Take your hand this time nice and stiff and flatten, pressing on your shoulder with the same amount of force. See what that feels like. Last one. Take your palm this time and meld it. Conform it to the shape of your shoulder and press with that same amount of force. How does your fascia respond to force? Which did you like better? Did you like the cup hand or maybe the pokey finger? Remember that later when you're poking the heck out of your victim, who might be your patient on the table. That's not so comfortable, is it? When you start engaging the fascia and you're working with people, make sure you use the broad surface of your palm. Or if it's a small person, pediatrics, maybe a couple of fingertips. You want to spread your force out over a large surface area, thereby allowing the pressure to be more even and comfortable for the patient. If you get in there with the pokey fingers, you tend to scare the patient away. They'll reflexively tighten up and guard against you as opposed to relaxing. So facilitate the release. Allow your own hand to be gentle, relaxed, not stiff, and you will also enhance your own proprioceptive senses. Your way of sensing changes in tension within the body will be greatly enhanced by a relaxed hand that completely conforms to the tissue. Ultimately, we're looking to use that hand to lengthen the tissues. We want to create a strain or lengthening of fascia. Now, naturally, this lengthening effect is something that we desire to do primarily for people who have abnormally short motion patterns, restricted range of motion, limited flexibility. What happens when we apply our myofascial stretches? Well, very similar to ordinary stretching or passive range of motion. You have two components of the fascial release. Like ordinary stretching, there is an elastic lengthening. Okay, we call that a temporary elongation or a temporary deformation of the fascial tissues. You have some lengthening of the actin and myosin, and that really affects more of the contractile elements. What is different about myofascial stretching, we call it a fancy form of stretching, is that you have a permanent or plastic deformation. There's a permanent lengthening of the tissues that's achieved with using myofascial release. This occurs because with the fascial release, we sustain our pressure. We maintain our stretch for a certain period of time, thereby calling in certain principles of physics for permanent structural change in the ground substance as well as in the protein filaments in the fascia. And then we'll talk about that a little bit more. In order to work with the myofascia effectively, you need to know the tissue characteristics. You want to be as precise as possible in applying the technique so that you can actually break restrictions in very specific locations. I highly recommend to break out your anatomy book and review a little bit about the anatomy or kinesiology of the muscles. Know your origins and insertions. Know especially the fiber alignment, because that will cue you in as to where to apply your technique and in what direction to apply the stretch. Think about a patient who comes into you and says, I have a terrible pain right between my shoulder blades. What is that? Could you take a look? So you get in there with your pokey fingers and you're checking out that space between their shoulder blades, and you feel taut bands of fibers that have a vertical orientation. When fascia becomes tight, you will feel as if these bands are almost like guitar strings that you can pluck with your fingers. Palpate for those bands. Think about what structure has a vertical orientation between the shoulder blades. Well, we know we have layers of muscle. You have rhomboids, middle trapezius, erector spinal muscles. There you have it. It's the erectors that have the vertical orientation, and knowing that that's the bands you felt identifies that it is the erector spinal muscles that are your target for myofascial release. If You also remember a little bit about your anatomy. You'll know there are depths to each tissue. The superficial layer has the skin and subcutaneous tissues. Then you have the deeper tissues. Rhomboids and middle trapezius are going to be more superficial to those deep erector spinal muscles. So in knowing that, you know you have to work a little bit harder, a bit more compressive force to access the erector spinal muscles than you would if someone had a restriction in their rhomboids. So if you don't remember the fiber orientation, break out an Atlas of Human Anatomy and refresh yourself. What diagnostic categories might be calls for myofascial release technique? Well, I reviewed the literature, and as you can see from this slide, there are many conditions that seem to be indications for myofascial release. How many of you have had patients come in with several of these conditions all at once in the same day? They go to one doctor and they say, oh, you have myofasciitis. The next doctor, I think it's fibromyalgia. Better take these drugs. Next doctor, oh no, you have a herniated disc. Well, there's actually three main components of myofascial dysfunction. Let's take a look at the three main categories. You have fibromyalgia, myofascial pain syndrome, and then, of course, somatic dysfunction or mechanical dysfunction. Let's do a differential diagnosis of these three categories and see which ones apply to your patient. How many people have you seen with fibromyalgia in your practice or even in your lifetime? It seems to be that there's a growing trend in this diagnosis across the board. I've traveled and seen over 200 different cities in the United States, and in most of those classes, at least 3/4 of the class raises their hand and says, yes, I have had patients with this condition. Let's take a look and see what differentiates fibromyalgia from myofascial pain syndrome. These are the nice people who come to your house with the following signs and symptoms. Oh, it hurts all over. I have headaches. You know, it's pain in my neck, then it travels into my back, and then I do some exercise the therapist taught me. My knees start to hurt and my shoulders, and the list goes on, doesn't it? And the pain moves, right? They come in with one pain, they leave with something totally different. So you feel like you need your track shoes on just to chase the pain around. What else do they present with? They're always tired. They're not doing those exercises you told them about. Matter of fact, many will flatly refuse to do the exercise because they're too tired. Every time they exercise, they seem to feel worse, especially if the exercise goes on for several minutes at a time. Let's think about what's happening with these good people. There's a good reason that they're tired, and there's a specific way to exercise with them that will benefit their system. We'll move on. Sometimes they present with headaches. Sometimes this entire constellation of syndromes gives you a headache. Think about it. Many present with those elegant complaints like, I got gas, I'm constipated. They have irritable bowel syndrome, digestive disturbances. This is all components of the fibromyalgia syndrome. And of course, aren't they very sensitive? Light touch is often too much pressure for them. I know these folks are in big trouble when they come into the office and say, nope, I don't want the massage. How could you not want a beautiful massage? Many of these people have been diagnosed with depression. And think about it. How would you feel if you had all of these signs and symptoms? There's a reason they're depressed. Most of the people who have fibromyalgia statistically are female. 85% is what's documented. But it's becoming more interesting to follow some of the men in the population, especially if you look into chemical factories, paint factories, where there's a predominance of males in the population. You start to see more incidents of fibromyalgia. Think about the toxicity that these people are being exposed to. And similar syndromes that have the same characteristics of fibromyalgia. Gulf War syndrome, for example. Exposure to high levels of toxicity and extreme stress. Think about that. Some of these are potential etiologies for fibromyalgia. Based on listening to my patients over my 20 years of practice, I've heard across the board from these people that there's some incidence of high stress, tension, maybe history of trauma or even abuse. So listen very carefully to these good people because they will tell you the apparent source of some of this problem. And of course you go crazy because you do your diagnostic testing and most of the tests are normal. You did your MRI, CAT scan, blood tests, typical lab tests, all come out normal for these people. You might do your medical exam looking at range of motion, goniometry, muscle testing, and they're kind of normal, typically 80% or better. Some might even be hypermobile. But what do we do when we test? Don't we do a simple break test for our strength testing? Think about checking these people out on repetitive testing. You will see a very different situation. And try palpation. Let's do a little experiment again. Break out the finger again and check out your lateral epicondyle. Check out your occiput here, the base of your skull. See if there are any tender points under there hiding. How about C5 to C7, the transverse processes, the widest part of your neck here? What about that upper trapezius? Reach around and grab that upper traps. How many of you can play guitar up here? Right? Very tender spot for many people. Deep to that and lateral, the supraspinatus, especially the attachment of supraspinatus. And what about the pectoralis, especially right here around the second and third rib? Pectoralis minor is often in one of these tender points. And right at the side of the hip, the gluteus medius muscle is a common tender point. The greater trochanters of the hip at the widest part of your hip. And then that little area just above your medial joint line of the knee. These are some of the 11 or more tender points that are classic for the differential diagnosis of fibromyalgia. How many of you are now a little concerned maybe someone won't be so comfortable with seeing your signs and symptoms? Fibromyalgia actually has very specific testing that denotes the problem. And this is something that we hope will start to be used clinically. There's a serotonin deficiency in these people. Remember serotonin, little happy chemical that manages sleeping and waking cycles, are disrupted when we don't have enough serotonin. In fibromyalgia, serotonin is depleted. Tricyclic antidepressants are often offered for these patients to help them to get the restorative sleep, so thereby their symptoms will start to dissipate. And think about what they complained about earlier. They're always tired, they don't feel like doing your exercises, because they get fatigued and sore from the exercise. They actually have a depletion of ATP. Remember the Krebs cycle? Well, we won't scare you with that, but the cycle by which your body metabolizes energy and creates ATP tends to be depleted in these people. Without ATP, you don't have the power molecule that makes your muscle contract. So how can we replenish the ATP? Well, some of the recent research is showing that if you boost their aerobic capacity with gradual aerobic exercise, increasing slowly over time, the course of several weeks, you can actually have a very positive effect on their aerobic metabolism, improving ATP and thereby decreasing some of the symptoms. In the clinic, I like to start the patients out with just a few minutes, less than 5 minutes of exercise on, say, the treadmill, the bicycle, UBE, arm exerciser, or maybe just some small weights, half-pound, quarter-pound weights that they could use for their arms and legs. You want them to use large muscle groups for continuous repetitive motion for several minutes at a time. Now initially this is going to be a tough sell. They will have no interest in doing that because they know they're going to be sore. Start them with maybe 1 to 3 minutes of each exercise and lots of rest in between. Then, visit by visit, lengthen the exercise duration and start to shrink the rest time. You'll find that they have a nice adaptive response, especially if you provide a little reward, do some myofascial release, maybe some modalities, some massage at the end of the therapy to make them more comfortable on their way out. Very, very effective to include that myofascial release. Work on those muscles that hold the tender points or trigger points, lengthen areas that you palpate that hold restrictions, improve their posture, and you start to see some of the symptoms dissipate. It's not a cure for fibromyalgia, but it is something that will help people to be more functional and have a better quality of life. This is really an autoimmune issue that needs to be handled from a variety of resources. I love to refer them to acupuncturists to make sure to look at the energetic components, look at the toxic components of fibromyalgia. I incorporate nutrition into the programs, so do consult with your local nutritionists. Get these people on good, healthy diets. If you think about what we're placing in our bodies daily between the coffee, the soda, sugar, white flour, white pasta, processed foods, we're depleting our reserves, and I think that that may be one of the contributing factors to the fibromyalgia syndrome. We don't know that yet in the research, but some of what is being done out there is now bringing about very nice results. So utilize that. If you find that there's a high stress level or history of trauma related to the fibromyalgia, then certainly do refer out for appropriate counseling so that people learn to be more resourceful and more tolerant of the stresses in their life. They learn to choose different behaviors when dealing with stress. Okay, through with fibromyalgia. In your differential diagnosis, you want to recognize myofascial pain syndrome, sometimes called mechanical dysfunction or somatic dysfunction in our osteopathic circles. What is myofascial pain syndrome, or MPS for short? Well, according to Dr. Janet Travell and Simons, who wrote the Trigger Point Manual, it's a muscular pain disorder involving regional pain referred by trigger points in the myofascial structures. Everybody's come across some trigger points, right? You touch a patient somewhere and they might jump, or maybe the muscle twitches a little bit. They have tender spots, hyperirritable areas in the body, usually as a result of a joint dysfunction or problem with the muscle. Let's take a look and see. You can palpate for these tender points in the body, sometimes called trigger points or tender points, and you find that there are often affiliated with them taut bands, thick, dense fibers in the muscles. Feel for those bands and document them. Most of us use SOAP notes for our documentation, right? You need good documentation to make sure you get paid. So when using your SOAP notes, in your subjective, you'll put down the patient's complaint. For the objective segment, under palpation, you can make a note. Positive taut bands in, say, the left extensor digitorum muscle. Might be related to a tennis elbow or the left lateral epicondyle. You can also measure the pain level of these points. Think about using the pain scale. Sometimes they call it the visual analog scale of pain. I like to just ask my patients simply, on a scale of 0 to 10, how much did that hurt when I pushed on you here? They go, oh, wow, I think that was an 8. And I'll document under palpation, pain scale 8 out of 10, pre-treatment. And I make sure that I document my post-treatment pain scale to show the difference. After the therapy, after you've done your magic, you may find that all of a sudden that pain scale's down to a 2. So you have an objective, measurable result from your therapy. When palpating the taut bands, if you find that someone does twitch on palpation or even jump from the sensitivity, you can document a positive jump sign or a positive twitch response. These are all very, very good for reimbursement, nice objective measures. These points also tend to weaken the muscle. So I invite you to check the strength of the muscles before and after doing your myofascial release. When you correct that length-tension relationship in the muscles, you'll frequently see better functional strength. These points can also refer pain to other areas in the body that seem to not be related. Maybe the areas are not in the same dermatome. But remember that the fascia connects like a web throughout the entire body. So there's nothing that escapes its influence. You may have a patient come in with headaches that are the source of tightness in the low back, or vice versa. If you look at the dural tube and where it attaches from superior to inferior, you have a connected link through the fascia. Even throughout the muscles themselves, someone named Thomas Myers, who wrote the book The Anatomy Trains, has documented all the different layers of fascia in the body. What muscles connect to what? And it gives you a good idea of where fascial pain could be referred to, especially when it doesn't fall within normal dermatomal origins. Let us now look at the source, the etiology of myofascial pain syndrome. We'll think of all the usual things that cause injuries: accidents, sprains, strains, work-related injuries, especially those repetitive strain injuries, people doing the same posturing, the same movement over and over again, eventually overstresses the fascia. That creates an inflammatory response with extra deposition of collagen, thick, dense fibers haphazardly arranged in the tissues. We need to get in there with the myofascial release and reduce some of those adhesions, release some of that tension to then bring about more normal mobility. Even underuse, deconditioning, can cause abnormal deposition of collagen in the tissues, resulting in stiffness. Post-surgery, of course, there's scarring that needs to be handled, and this can be managed effectively with myofascial release as part of the component of your entire program. Now, to find these areas of myofascial restriction, you probably are already aware of how to examine a patient. You can use your goniometer and measure range of motion. See how many degrees of limitation a person has. That's a primary method. If you do flexibility testing, you can look especially at joints that have multiple muscles crossing over them, or multi-joint muscles, such as the hamstrings. So special flexibility testing can be used to identify areas of myofascial restriction. If you are aware of how to test for joint plane component motions and you practice joint mobilization or manipulation, using those joint play testings can also reveal the sites of the deepest fascial restrictions, particularly in those joint capsules. Some of us are more expert at palpation. So use those fingers to get in and palpate for tender points, trigger points. Palpate for those taut bands, so dense areas of tissue that don't move as well. Check on the patient bilaterally. See what their normal is. All of this can give you an idea of where to assess for myofascial dysfunction. We'll start today with an evaluation of posture. We're going to keep it very basic and very brief because there are certain effects of muscles that hold your posture that cause more restrictions to develop in certain areas of the body. I'll give you a little cheat sheet so you can see where these restrictions tend to develop. There's actually two main types of muscles in the body. You have your tonic postural muscles and your fast phasic muscles. The tonic muscles, the postural muscles, are the ones that tend to develop the most myofascial restrictions. Interesting. Those are the muscles that have to contract repeatedly over time and tend to get a repetitive strain based on the poor positions that we hold them in. So one of the first things you'll do is look at your patient and see where are they holding tension. Maybe they have too many spinal curves. Maybe there's a pelvic shift. If you're interested to learn more about posture, look at the work of Florence Kendall, physical therapist. There's a nice listing in your reference bibliography, Muscle Testing and Function. Another text, which is a great resource, Clinical Orthopedic Physical Therapy by Richardson and Inglarsh. Both of these have fabulous information on posture. For today, we'll keep it simple. Look for symmetry. Get a person to practice with, maybe someone in your family or in your clinic, and look at that person from the front, the side, and the back. We'll go over this a little bit later in the lab, but view especially for symmetry. Check the major joints of the body for alignment, check the major bony landmarks, and if you see that they're out of alignment, palpate the muscles that hold that position and see, are there taut bands, are there trigger points in those regions that could indicate myofascial restriction. And there was an interesting study done in the Journal of Manual Medicine, Volume 5, 1990. They actually looked at people with fibromyalgia syndrome, and as their treatment, they did posture correction. Interestingly, they had a very positive response with a reduction in trigger points or tender points in the fibromyalgia clients who had the postural correction. So knowing how to correct the posture is automatically a component of your myofascial work. Let's look at those postural tonics. I've given you a list there in your manual. These are the ones that develop the most restrictions. So if you don't know where to start looking for myofascial tightness, definitely check those postural tonics. Check the spinal erectors. Very commonly, they develop taut bands. Check the pectoralis major and minor, and the upper trapezius. How about also checking the hip adductors, the hamstrings, tensor fascia lata, and iliopsoas. These are very common sites of fascial dysfunction. And in the lower legs, check your gastroc and soleus. Check also that little pain in the butt, the piriformis. That too tends to develop restrictions, often leading to the common complaint of sciatica. If you know motion testing, do those joint plane component motion tests. Check segmental and regional motion analysis. Break out your goniometer and find where there are areas of limited flexibility. That is where you want to start working. I prefer to work on the most restricted area first and then branch out from there. Palpation is probably your greatest resource when you're working with myofascial release. You can palpate from superficial to deep in the tissues, layer by layer, to determine which layer your fascial restrictions lie on. Your hands never lie, so trust what you sense with your fingertips, with your palms, because if you felt it move, it moved. Many of us sit and analyze what we palpate and question ourselves, if you felt something move, it definitely moved. If you felt it was stiff, accept what you sense is real, in the words of Dr. Upledger. We'll do a fascial layer assessment from superficial to deep. You could try a little bit of this on your own body at this time. These are the very techniques we'll use to assess and treat the myofascial restrictions. Try working on the side of your arm to start. Superficially, just rest your fingertips over your erector muscle mass. And very lightly, with very soft pressure, glide your skin over the underlying tissues. Just very light pressure, you'll see, will cause those tissues to glide. Imagine the face of a clock on those tissues. Can you move the tissues toward 12 o'clock, 6 o'clock, 9 o'clock, 3 o'clock? Do the tissues move equally all around the clock? So we're looking for quantity of motion. And notice it takes very light pressure to move the skin. Compare to the opposite side and see what's normal for that patient. This is your skin gliding. This gives you a nice idea of the superficial restrictions that may be evident. That will definitely be tight in someone who has had scars or adhesions post-surgically, after burns, or even in joint contractures. The skin tends to also become taut and thicker in that area, so you'll find less skin glide. Compare the cubital fossa of your elbow with your olecranon. Look how much more the skin glide is over the olecranon than over the cubital fossa. So you'll see there's normal amounts of skin glide on different people. In order to figure out what's normal, unfortunately, no one has yet done a research study that I'm aware of that measures how much skin glide should be available over the different body parts. But by experience, testing on different people, young, middle-aged, older folks, see what's normal for that individual. Compare side to side, because you want to return them to their normal functional level. You can also do tissue rolling, and that is basically gripping the tissue between your finger pads and rolling the tissue. You can actually lift the skin, and there should be some mobility to push and roll it. In people who are very tight, this will be very pinchy or even painful. So we use this rolling to release superficial adhesions, but we always make sure we work within the tolerance of the patient. As you go deeper, you find you can actually grip the muscles. In this case, you have your brachioradialis, your extensor digitorum, extensor carpi radialis muscles. Grasp those muscles on their sides and see, can you move them at a right angle to the axis of their fibers? Take a look and see. Move them transversely. That's called muscle play. How much muscle play do they have in one arm compared to the other, or one leg compared to the other? All muscles should have some ability to move and glide past one another to contract effectively. When those muscle bellies stick together, they move en masse as a group, and you see substitution patterns, compensatory motions that are not resourceful for the patient and lead to pain and dysfunction. So take a look for that. You'll find that when working on the body, you want to start superficially with the tissue glides, very gentle, releasing those surface adhesions, and then gradually working deeper into the deeper structures such as the muscles, separating one from another and restoring normal glide and play between and within those muscles. When finding areas of myofascial restriction, compare bilaterally on the same person. Get a sense of what's their normal. As you have the experience of testing more and more people, you'll start to sense what's normal right away. Remember, this is also an art. It's not just a science. We'll start with a structural assessment. We'll do a posture check. Pick a person to do a simple postural analysis on. Look for symmetry. Check them out from the front, the side, and the back, and measure all the different levels, both with your eye and by palpation. Feel for symmetry. If you find areas of asymmetry, ask yourself, what muscles do that? What muscles cause that head to be tilted a little bit to the right? Oh, sternocleidomastoid, upper traps, splenius, etc. Scalenes. Palpate those muscles that look like they're tight and see, do they hold taut bands? Are there tender points or trigger points in the region? And of course, measure the mobility of that area to see, is there a limitation in range of motion? This will start you on the road to finding the restrictions, and then of course working with them with the myofascial release. See if you can even identify on one person at least 3 areas of tightness and start to work on them. And I recommend, if the area is not too painful, treat the most restricted area first. Now let's get on to the techniques. Soft tissue mobilization and myofascial release are pretty much synonymous terms that we'll use today. We'll use the MFR for short. Today's techniques of MFR are basic techniques used on an introductory level, both for your patients and for you as students of myofascial. I've chosen only techniques basically for the goal of improving range of motion to improve mobility. So we're going to be applying a very controlled force to the tissues of the body in a very precise direction for the purpose of improving mobility. Myofascial release can do more than just improve mobility, but to start with the techniques and get a sense of how to work with the body proprioceptively, it's easy to work with the range of motion. It's also something that's objective and measurable immediately upon the completion of your releases. How do we perform the myofascial release? Well, first, of course, you must identify the restriction. Use your tissue glides, use your range of motion testing, use some muscle play testing, use a posture assessment. If you found, for example, that someone had a tight pectoralis minor muscle, you may notice that on their posture exam, their shoulder is somewhat forward. We would say a protracted shoulder or rounded shoulder. Think about the origin and insertion of the muscles that perform that action. Here from the upper ribs to the coracoid process, you have pec minor, and then of course pec major from the sternum to the superior proximal humerus. Take a look at how those muscles work. You're going to apply gentle pressure to stretch that area, and very commonly we'll stretch the muscle through its length across origin and insertion. So stretch to the end of the motion barrier and hold. Now you're going to be holding that for quite some period of time, so be patient. Average time for myofascial release is about 90 seconds to 2 minutes. So make sure that you are comfortable during the holding time. Make sure the patient is in a comfortable position because you may be there for a while. During that period when you're holding the stretch, because remember, it's just a stretch, hold it still, completely still, so that nothing is moving. That point at which you're holding everything is still is called, of course, the still point. That term will come up again in more advanced versions of myofascial work, such as craniosacral therapy or visceral manipulation, when we're working with other fascias and we're holding the fascia very quiet for a period of time, that 90 seconds or so. Now, no fair looking at your watch and saying, are we there yet? Not about the watch. It's about sensing proprioceptively with your hands the changes in tissue tension in the body. Going to feel for that shift in tension. As the release occurs, the muscles and fascial tissues will begin to lengthen. You'll feel a very, very gentle tissue creep, we call it. A lengthening, a softening of the area. You may see that erythema response occur. Remember those histiocytes, those mast cells secreting histamine, get a nice vasodilation response. So look for that redness in the skin and the heat increasing the circulation in the area. These are all components of the actual release. Feel for that shift in tension that is the harbinger of the myofascial release. Now, holding the stretch for the myofascial release, remember you want to be about 90 seconds, an average. Feel for the softening, feel for that release. You will feel a warming in the tissue as a vasodilation response occurs. Sometimes you'll even feel what's called a therapeutic pulse. You'll feel a very slight pulse, as if you're feeling a pulse right at your wrist or at your carotid. When the vasodilation occurs, circulation flows into the area and it makes the pulse more pronounced. So feel for that. That's actually a good sign. Typically, the skin warms as the tissue starts to soften, melt down, and improve in flexibility. So the key is, when you're through the still point, the tissue starts moving again. It's softening, lengthening. Feel for that to occur because that is the release. At that point, you have two options. You can take up the slack again and do another release. Typically, I like to do 2 or 3 releases in a given region and then gently withdraw my hands and reevaluate the tissue. Reevaluate the tissue glide, the muscle play, reevaluate the goniometric range of motion, and see, is there any change in the pain or the tender points? That way you're always testing and reassessing to see, are you creating a change with the myofascial work? Now there's two main phases of myofascial release that you'll be practicing, particularly in the lab section of this video, and that will be taking up the slack, which is providing the stretch to the tissues, the lengthening, and waiting for that tissue creep. That's the osteopathic term for the release. Now, how does this myofascial release work? What's actually happening in the body tissues? Well, the mechanism of action is very similar to standard stretching techniques. Of course, there's an elastic stretch to the tissues, stretching the contractile elements. But unlike passive range of motion, myofascial release affects the actual ground substance and the connective tissue proteins. Sustaining the pressure and maintaining the tension incorporates principles of physics. You're actually breaking abnormal crosslinks that occur, covalent bonds that form abnormally in areas of abnormal connective tissue tension. So feel for those crosslinks breaking. That is the lengthening effect that you feel. The softening is the reduction of the viscosity of the ground substance. Remember the jello that the proteins are floating about in? That ground substance jello melts down as a result of the sustained pressure of the myofascial release. So feel for that melting, feel for that softening. And there's an interesting bioelectric effect that occurs. And if these effects interest you, you can look at the work of Cantu and Grodin. In your reference list is a book called Myofascial Manipulation that gives a lot of background information and also some great histology pictures of the fascia itself, what the restrictions look like. So check out those resources. In the piezoelectric effect, sustained pressure on the body tissues could create minute electrical current charges to flow in the body tissues. And accordingly, the fibroblasts that create the connective tissue will line up exactly along those lines of electric current flow. You can resource the text by DiGiovanna and Shiowitz, The Osteopathic Approach to Diagnosis and Treatment, for information on how those fibroblasts move. So we're now using Wolff's law to create minute electrical current charges in the tissues according to this theory, and those fibroblasts will line up the same way. If any of you are already practicing electrotherapy, you're well aware of the alignment of the tissues in response to electrical currents as we use electrotherapy for tissue healing. Little reminder now, your primary indications for today's intro level myofascial techniques are to improve limited range of motion, enhance flexibility, restore normal joint plane component motions, decrease some of those crosslinks, those adhesions, loosen up the scars, and thereby reducing spasm, pain, and improving function in the body. I think it's also really important to look at the contraindications or precautions for myofascial release. Let's take a look at a few of these. Many of these are actually precautions. You may be able to use the myofascial releases, but you need to modify your technique, possibly modify your patient position, your force, your direction of pressure, so that we're not injuring anyone. If someone has a malignancy, clearly malignant tumors should not be mobilized. Pieces can break off and move into new and exciting areas of the body where we don't want them growing. So in the event that someone has a history of cancer or any symptoms of cancer, we make sure to contact the oncologist and find out, can we get medical clearance to work on this person? We don't like to work over areas of tumors, but with proper medical clearance, you may find it is very safe to utilize some of today's techniques, especially the gentler ones such as tissue glides, some cross-hand techniques you'll learn about, and some muscle play. If someone has an aneurysm, clearly we don't want to be putting pressure across the bellies of people with an aortic abdominal aneurysm. It could kill them within minutes, and that would be, of course, a disaster. So if you think someone has a history of hypertension, especially extreme hypertension, be aware that they need medical clearance prior to using these techniques. Hematomas, unhealed tissues. Many people have bruises, black and blues, ecchymoses on the body. We definitely don't want to put any pressure or stretching across these areas because they are not fully healed. You could cause bleeding inside, which will then cause possibly calcium deposition in the tissues, heterotopic ossification, myositis ossificans, which again, of course, would be a disaster for the patient. So stay away from those bruises, wait until they're fully healed. Acute circulatory conditions are commonly something that people present to you with. Maybe they have a history of heart attacks, myocardial infarction, perhaps they've had coronary artery bypass surgery, or various other circulatory conditions. check with their physician. I like to get on the phone and speak to the cardiologist or the primary care physician and find out, does this person have patent enough circulation to tolerate the increase of circulation with myofascial release? Most frequently, we simply have to monitor them, take the resting pulse, blood pressure, respiratory rate before using your myofascial technique. And then after a few minutes of using the technique, measure these vital signs again and see, are they remaining stable, or is there a challenge to the system? Compensation. In that event, perhaps they're not optimal candidates for myofascial release. In the event of things like acute infections, acute inflammations, today's techniques are not the techniques of choice. These things require more of an anti-inflammatory approach, rest, ice, compression, elevation, and then when we reach the subacute and chronic stages, that is the time to apply the myofascial release effectively. There are other medical managements that are needed in the acute stage, or other therapeutic managements. More advanced versions of myofascial work, such as craniosacral therapy, or some light osteopathic techniques, such as counterstrain or very gentle movement, might be indicated, but today's techniques would not be the best. Occasionally, people present with skin hypersensitivity. How many of you have treated RSD, reflex sympathetic dystrophy, complex regional pain syndrome? These are conditions in which the skin is hypersensitive, usually due to some type of a trauma, perhaps a fracture, a sprain, or an accident. People develop very sensitive areas with the RSD. This is also true of people with burns, people who have even extreme fibromyalgia. So we stay away from the areas of hypersensitivity, but you can work in an area remote from that hypersensitive region and still influence it. Remember, the fascia is like a web that goes through the whole body. And if you think of a spider's web, you have a spider in one end of the web and a little tiny gnat lands in the other end. How does she know it's there? You bet there's vibrations that extend three-dimensionally through the web, telling the spider exactly where her lunch is. Fascia behaves in an identical manner to the spider's web. Lines of tension emanate from a lesion in the fascia, three-dimensionally. So you can work anywhere across that web and influence the lesions in the web of fascia. So do utilize that. Very, very helpful to work in the periphery of an area that's hypersensitive, and gradually as that sensitivity declines, you can then sneak in slowly to the area of primary lesion. Many of our patients actually present taking blood thinners, anticoagulant drugs, Coumadin, heparin, even things like long-term steroids or chronic debilitating conditions may cause the skin to get very, very sensitive on these people. And of course, the blood vessels, especially microcirculation, can rupture easily. So no pokey fingers, no deep techniques in people who are taking those blood thinning drugs or are in a condition where their skin or circulation is very fragile. You don't want to leave marks on the body. You don't want to leave ecchymoses, because their lawyers would love that. You have to definitely avoid that. In cases of obstructive edema, sometimes there's just too much fluid in between my hand and the target tissue. In that case, I might refer out for manual lymph drainage or medical management if there's too much edema. But today's techniques, not likely to be the best choice. Severe diabetics tend to bruise easily, and the skin is very fragile. So if you start pulling hard on the skin of a diabetic, it might tear. And that could be a problem, leading to infection, poor healing, right? So definitely be very gentle on those folks with the diabetes. It's becoming a more common problem, and you'll need to see just how gentle you can be. Test a small area when treating these people initially and find out what their tolerance is. In the case of osteoporosis, clearly brittle bones don't want to be pushed on. Pushing on the brittle bones could cause fractures, lawsuits, and extreme pain for the patient and for yourself. So let's go very gentle on those nice people with the osteoporosis. And of course, the big no-nos, healing fractures, open wounds and sutures should be totally avoided with today's myofascial release techniques. If you work over or near an area of healing fracture or an area that still has sutures or unhealed tissue, if you start applying tension across those structures, you will create a non-union, a malunion, or some other problem affecting the healing negatively. So we want to make sure, clear with physicians first, when is the person ready to be worked on with today's techniques. And I highly recommend, make a good referral base. Speak to the physicians that are caring for your patients educate them about the myofascial techniques. You know, sometimes you call them up and say, hey, I'm working on Joe Schmo, and I'd like to find out, you know, he had a heart attack last year, and he's diabetic. He also has a hip replacement and a knee replacement. Oh, and by the way, he's very sensitive in his right shoulder since he broke his leg and his arm. So I need to know, is it safe to work on this person? Now, at that point, the doctor can make the decision, is it okay to work with that person? They might let you work on an area remote from the area of fracture until the fracture is done healing. Or, consequently, the doctor might turn around and say, I have no idea of what you're talking about. What is this myofascial release? Is that about the face? I've actually had doctors ask me that. So it's a great opportunity to educate them, explain how this is a special form of stretching that gets a more permanent lengthening in the tissues to improve this person's mobility. So you want to be very direct and very objective when explaining how to use these techniques. There's always more to learn. You not only use all the brains you have, but all that you could borrow. And thinking beyond just people. Some of us have furry friends in our lives, right? We have dogs, cats, some of you may have horses. Don't forget, they have fascia too. So if you know their anatomy, and you can learn that, you can help them as well if they're having tension and pain as a result. Animals can benefit from myofascial release. Let's now move forward into a couple of treatment guidelines. These general guidelines are those that I have formed on my own based on my 20 years of practice in physical therapy. I've worked in several different venues of therapy, including pediatrics, neurology, orthopedics, cardiopulmonary, and rheumatology. So these have all been developed as guidelines based on my experience with these people. In terms of program planning and sequencing of techniques, remember, everyone has the opportunity to change. Whether their body chooses to change at the moment you're interacting with them is another question. But at least with the myofascial release, you're affording them the opportunity to get some mobilization, get their mobility back again. In the event you check a person and you find out that they have limited joint play, you may think, joint mobilization or manipulation might be indicated for this person. And those are usually somewhat forceful techniques. I recommend try the myofascial release first before moving into the heavier handed techniques. You'll be pleasantly surprised to see that it saves your hands, and it's also a lot more comfortable for the patient, and in some cases you might not even need that mobilization after using the myofascial work. You may just get that adhesion to break and the circulation and mobility to open up. If you're working on someone who's in pain, it may be useful to work a regional restriction first and then localize to the painful area later. Imagine a muscle with a big trigger point. Don't just dive into the trigger point. It might be too painful and tender for the person to tolerate. Instead, work the region, perhaps the origin insertion of the muscle, the sides of the bellies of the muscle, to free it up, sneaking from the outside in. Generally, you can melt the restriction by working the periphery and then localize into that area of pain as it starts to subside. Most of today's techniques actually will work very directly with the tissues. Direct technique is an osteopathic term that's basically suggesting working in the direction the tissues do not move. So you're engaging the barrier to motion. The shoulder won't flex, you flex it. That's direct technique. There are other techniques called indirect techniques, which are more commonly used for craniosacral therapy, visceral manipulation, and very gentle myofascial. We go in the direction the tissue wants to go. That's another story, and we'll look at some of that in level 2 of this course. We'll start from superficial to deep in today's course, working the surface tissues first to allow us to get access to those deeper regions. So we'll test layer by layer to see where do the restrictions lie. And based on the layer, we'll use lighter pressure for the surface tissues and then deeper pressure to access those deeper restrictions. You can also add tractioning techniques, three-dimensional stretching, tractioning through the arm at all different angles, tractioning through the leg at different angles, or the neck or the back. Using the tractioning stretches all of the myofascial components from the surface all the way down to the joint capsules. And that is something that's very, very useful to speed up the release and to work at multiple angles at the same time. So we'll practice a little bit with the 3D tractioning too. Now that the release is done, person's lengthened in some of their fascial tissues, they have greater mobility, what's next? Well, you can open up your bag of tricks. Perhaps you know exercises. Therapeutic exercise is a fabulous thing to follow the myofascial release with, so they start to incorporate that mobility again into their everyday living. Functional activities, ADLs we call them, activities of daily living, should be incorporated. Neuromuscular re-education, retraining the proprioceptive senses in the body. You know, if someone's been tight and lifting their shoulder like this for so long, maybe they've had a frozen shoulder for 6 months, and they hike up their scapula. Once you restore glenohumeral motion, you'll find they're still hiking the scapula because it's a habit. So use your PNF, proprioceptive neuromuscular facilitation, use your therapeutic exercise, your NDT, your sensory integration, whatever it is you do to re-educate those muscles to function optimally again. So remember, after the myofascial release, teach your postural re-education, neuromuscular re-education, ergonomics, because if they go back to doing the same silly thing that created the restriction, it's going to rebuild itself. So make sure to include that aspect of patient education before they leave your office. Don't allow them to go back and rebuild the restriction. Once you release it, it's gone, but they can get that same stress going, and the problem will then begin again. So remember, we're treating with the whole picture. We're not just treating with myofascial release, but lots of patient education. And the fact of the matter is, not everything will always release. So if you don't get good results when first trying the releases, try something else. Many of us tend to be a little heavy-handed. We think more is better. We think pushing into the tissues to make that release happen will be a better thing to do. Believe me, it's not. Lighter pressure often is better. You get a better release. It's less injurious to the patient and more likely to be comfortable. So for the purpose of learning today's techniques, gentle is best. Now, as you may be learning, some of the finest technology we're using is right here within our own hands. We could both evaluate and treat, often simultaneously, using today's myofascial release techniques. However, you may be aware of other technologies that you'd like to incorporate into your therapeutic regimen for this patient's treatment. In that case, I recommend, if you use therapeutic modalities, consider using a thermal agent prior to performing the myofascial release. If it's a surface tissue that's involved, something as simple as a hot pack or paraffin may be useful to warm the tissues before the myofascial. If you have a deeper structure, you may think about using diathermy or thermal ultrasound to get that depth of penetration into the tissues. And if you think about it, when someone has a workout or they start a new stretching program, they might get a little sore afterwards. You're breaking some of those adhesions as those tissues lengthen. In that case, it would be well to educate the patient, if indicated, in the use of cold agents, cryotherapy. Teach them how to apply ice packs to the area or ice massage to decrease that inflammatory response, that delayed onset muscle soreness that is very common post-exercise and also post-myofascial release. I typically will treat the patient before they leave my office with the cryotherapy. If they are very, very sensitive or inflammatory, I might even use electrotherapy prior to them leaving the office. And I like to instruct them in use of self-range of motion, self-massage, even self-myofascial release. Instruct them in the use of liniments if it's appropriate to help to make them more comfortable. And of course, in the use of ice to decrease any post-inflammatory response that may occur. Let's get right into the techniques. You're going to turn to part 2 of this DVD, and in part 2 you'll see each of the releases completely described live for your advantage. Make sure to set someone up to practice with in a comfortable location, and be aware the positions that are being displayed are suggested postures for both the therapist and the patient. You may use any positioning you wish that is indicated for your patient. Make sure to check your body mechanics too. Having your body in an inopportune position will stress your own ligaments, your own joints, and you'll be too tired to be able to do much of this work. So keep yourself in an excellent biomechanical position. Make sure to avoid hyperextension of your joints. Keep them closer to neutral. And with many of the techniques, we'll be using our palms, our fingers, thumbs, knuckles, or even elbows to help to save your hands. In any case, don't strain your body in any way to perform the techniques. Find a new patient position or a new hand position for you as the practitioner to be as comfortable as possible. The more relaxed you are, the more you will sense the changes in connective tissue tension in the body, and the better you will be able to practice the myofascial release to get those results that you're after. Approaching the patient initially, you're going to approach with very gentle, flat hands, remembering our concept of biomechanics that you want to distribute a force over a large area in order to avoid noxious stimulation of the tissues. I'll explain to the patient, I'll be doing an examination of the tissues of your back and the skin. You'll feel some movement on the skin over the tissues, and let me know if you have any areas that are tender or painful. And the practitioner is looking for areas of tension, tightness, restriction, gliding the skin medially and laterally over the underlying tissues. Okay, proximal to distal, and also superiorly, inferiorly. So superior glide, moving the tissues up, inferior glide, moving them down. And you're looking to see the relative resiliency and elasticity of the tissues, such that as I'm moving up, superior glide in the low back, what does the end feel like? End feel is a perception of restriction that you feel, or the resistance you feel at the end of the range of stretch. You could have an elastic end feel, such as right here. You can see the bounce in the tissue. I come a little bit lower, however, you see that this tissue does not have that same level of elasticity. Superior glide is elastic and bouncy, very resilient. Inferior glide has a more abrupt stop to the motion, and you can therefore localize to see, is it coming from the cervical spine? That is also restricted, which is very typical because the tissues are held more closely, apparently at the base, which is a supportive structure for the head. Superior glide is nice, bouncy, resilient. Come down a little lower. A little bit of a bounce on inferior glide here. Plenty of elasticity for superior glide. And you could come down basically segment by segment. Here you have fairly good glide in both directions, etc. I use two hands to be able to work on a good area of the body at once and save time. And he has nice resiliency over his low back. You could compare bilaterally, one side to another. And again, his primary restriction is coming up here around T3, very poor inferior glide, T3 to T5, plenty of superior glide. Check also oblique angles. And the skin should move fairly freely in most directions. The way to tell what's normal, since it has not yet been documented to my knowledge, is you need to practice and feel this on numerous people. And also compare on an individual side to side. So you'll find there's plenty of motion in the skin, particularly over the joints. A little bit less motion where the body holds its fascias a little bit more closely on the areas of stabilization. So that's our tissue glide. There has been a study that came out in the Journal of Rheumatology looking at benign joint hypermobility syndrome, and it's one of the few studies I've read that showed a direct correlation between the tissue flexibility and skin mobility relative to the joint mobility underneath it. And that's documented in your handout. Tissue rolling is our second assessment technique, and that would be using a pincer grip, using the pads of the fingers. We're going to use a pill rolling type of motion, gliding the tissues with our thumbs and feeding the tissues up into our thumbs with our moving fingers. Now the tissues here glide nice and evenly. You should be able to see a good picking up of the skin. Test centrally over the back and then test over each of the paraspinals. And here we see nice free motion throughout. I generally work from superior to inferior, but no reason you can't start from the inferior and work superiorly. If someone is tight in the back and you start down low, you may find it's difficult to start at that point. If they're very tight, you may also find that alternating the tissue rolling is a nice way to gain access and a better purchase of the tissues, and also to start some of the releases of the tissues. If I find an area is restricted with the skin rolling, I may do 3, 4, even 5 skin rolls over that area to soften the tissues. And once you've assessed your glides and skin rolls, you have a concept of where there may be tension in the tissue. You could even work three-dimensionally, doing a shear, clockwise, counterclockwise, just to get a sense of where there may be tension in the body. I spend probably less than half a minute actually doing this over an individual area of involvement on a client. It does take a little bit longer to describe to you. Now, if you found tissue glide is restricted in the lumbar spine, for example, if the tissue glide was restricted superiorly, you would take up the slack of all the tissue moving superiorly, use another hand as counter pressure over the sacrum, and move that hand inferiorly, such that the glide has your hands moving a force in opposite directions, taking up the slack to stretch the tissues between my palms, as such. And make sure your elbows drop down, make sure your fingers are relaxed. Don't allow yourself to be hyperextended or have fingers tense in the air. Let everything relax. You'll perceive more motion in the tissue, and also the patient will be encouraged to relax at the same time. To achieve the release, you simply take up the slack in a given area, wait approximately 90 to 120 seconds for the release, which will feel as if you're able to just put as much pressure as possible here and not receive any additional motion. No matter how hard I push, that is the end of taking up the slack. That's the barrier to the motion. So hold that barrier for that 90 to 120 seconds. And after about that much time, you'll start to feel the tissues will begin to glide or creep. That's called tissue creep. It's very subtle lengthening of the tissues that will be heralded by slight movement of the tissues underneath your hands, which may be appreciated by the client as well. It's good to educate the client while you're holding the technique, holding the stretch. Let them know you're stretching the tissues to help to achieve a greater range of motion. And also let them know that working on deep breathing will help to facilitate the release and also to help them to be more comfortable. So have them work on some abdominal breathing exercises. Okay, so there's a little release right there. How does that feel, Tommy?
Feels pretty good.
Feel just a little lengthening?
Mm-hmm.
Okay, so always communicate with the patients exactly what they feel. Make sure it matches what your perception is of the motion. And I'll follow through into another release. I've taken up the slack again. I'll wait that 90 to 120 seconds, or whatever time it takes. You may find on people with very high tone issues, it may take several minutes. I've had releases occur in a matter of several seconds. So it's really up to the individual patient. Go by your sensation of the release. Go by the change in the tissue creep and the improvement of mobility to decide when to disengage. So I followed through 2 or 3 releases here. I'm going to gently disengage my hands and reassess the tissues again and see what is the superior glide like, or if it was inferior glide that was limited, check that. It's a good idea to assess bilaterally. What is the tissue glide like, left side versus right? You can check oblique angles, and these same areas that you assess are the same areas that you'll treat. From the lateral perspective, many people develop tension and restrictions along the borders of the paraspinal muscles, the erector spinae. So I'll use the palm heel of my hand just at the medial border, lateral to the spinous process, take up the slack in the tissues, and feel for the glide. Here I'm using a little bit more compression because I'm moving beyond the skin into the underlying muscles. And I'll test, I see it's a bit tighter in the mid-thoracic spine, upper thoracic spine, which matches some of the restriction we identified before, and I would do the same thing on the other side. I tend to work pushing the tissues away from the body. It's easier to have my body weight behind me and to keep my joints as neutral as possible to achieve the technique. If identified there's some tension through this area in the mid-thoracic spine, I could take 2 hands there, take up the slack in those tissues, start my release, and hold. Wait that 90 seconds or whatever it takes until the tissue melts down. Frequently, a release is also heralded by having release of tissue temperature. You'll feel an elevation of temperature in the area as the circulation opens up. Frequently, you may feel what's known as a therapeutic pulse. There'll be a pulsing in the area or a tapping sensation, which you and or the patient may appreciate, and that's also a nice sign that the circulation is opening up in that area and you've achieved a release. These releases should feel pretty good as well. They should not be uncomfortable. If they are painful, you may wish to choose to do something else. You may decide you're actually pushing a little bit too hard on the body. Use only the degree of force you need to access the restriction and line up those restrictions 3-dimensionally with a stretch. Whatever vector of tension you discover is the tightest. For example, if I found some tension moving laterally in the mid-thoracic spine, I might check to see on an oblique angle, is it more tense up to the right, down to the right, or straight out to the middle. And actually his tension is greater. Feel the difference here, Tommy?
Yeah, I do.
Okay, and he perceives the same thing. So I'm coming down, altering my angle of force to match the vector of tension in his body. And that's simply by stressing the tissues with the tissue glide, taking up the slack, and holding. Now, laminar releases are done generally with 2 hands or 1 hand, but the force is in one direction, taking up the slack in the tissues to stretch the myofascial structures, and then waiting for the hold and the release. This helps to glide one layer of tissue on another to achieve releases from superficial to deep. I use a deeper compression to access the deeper structures, and a more soft, superficial compression to work on the skin and subcutaneous tissues. You can also do the cross-hand release, which is biomechanically more efficient, crossing your hands and gliding them apart from one another, as we did with this lumbosacral cross hands, unilateral lumbar cross hands, testing both sides, oblique cross hands, etc. So follow the pictures in your manual and try out some of those techniques. Sometimes people become restricted in the interscapular region, and you can work with the cross-hand techniques at the interscapular area, working at different angles as well, with a little bit of torsion, taking up the slack, and waiting for that release. In areas where people have their shoulders wrapped up around their ears, as they commonly do, you'll find an elevation of the scapula. Now here, Tommy, if you put your arms at your sides, the scapula would assume a more neutral position. You want to access the superior border of the scapula on either side, take up the slack with a scapular depression movement. You can test that area and see what is the flexibility like for scapular depression on the right side compared to the left. And actually, he's a bit more restricted on the right side. How does that feel to you?
I feel more restricted on the right.
Okay, so he agrees. It is a bit tighter here. I have more elasticity and a greater range of motion of scapular depression on the left compared to the right. If I wish to treat both, I could simply line up my hands, take up the slack in both, and wait. 1.5 minutes or 2 minutes. Feel the glide. You'll feel that scapula drifting down, and then reassess the technique again. I could use 2 hands over that one scapula and work unilaterally, or I could choose to work bilaterally. If I felt it was difficult to stabilize the neck, if it was so tight that his head was elevating, I could use a cross hands over the scapula here, maintaining stabilization at the base of the occiput. And if that hand was tired, I could simply switch hands. So it's all the same release, scapular depression, but working at different angles for your comfort and for the comfort of your patient. Okay, and the same releases that we have used to work on the back, we can work over any of the major joints of the body, particularly where they tend to close down into flexion. So your flexion contractures of the hip, the knee, and the ankle are excellent areas for the cross-hand release. For the flexion contracture of the knee, you just hold that there. We'll make believe you have a flexion contraction. Have one hand over the hamstrings, the other hand over the gastrocsoleus muscle belly, and then using a glide in opposite directions, take up all the slack in the hamstrings, moving superiorly, gastroc moving inferiorly to stretch the posterior knee fascias. Notice, in order to protect the patella and avoid patellofemoral compression, we have put a pillow roll underneath the quads on this side. Now coming down to that tight Achilles tendon, gastroc area, you want to have your web space of your hand cupping the calcaneus to give a dorsiflexion moment, dorsiflexion force there, and your opposing hand is holding the gastrocsoleus, separating in a cross-hand release this way. To get an even stronger stretch, I'll often use my thigh to passively dorsiflex the patient's ankle and then distract with my lower hand and cross-hand release with the superior hand right over that ankle to stretch out the Achilles tendon. Okay, now turning to the anterior aspect of the body, you can assess with the tissue glides here over the anterior shoulders, anterior sternum and chest, just like we did on the back, medial lateral glide, superior inferior glide. You check the same over the abdomen, taking care not to apply any direct compression to the xiphoid process, which is the midline bony prominence that projects inferiorly from the break in the rib cage, right here. Very easy to fracture, so no direct pressure there but just check the skin glide over the ribs. Many times people who have a seatbelt injury from a motor vehicle accident will have rib dysfunctions and decrease of skin glide over the chest and sternum. In females, you can simply drape over the chest area and explain to them the use of the skin glide and the tissue glide to check for mobility restrictions, maintaining your pressure above the breast tissue or below on the ribs. So for his glide, superior glide and inferior glide are both unrestricted here. Medial and lateral a little bit tight around the border of the pecs. As we found when looking at posture, many people have a forward shoulder posture, forward head, and tightness along the anterior and inferior fascias of the shoulder and pectoralis. In this case, we can use a cross-hand release to the pectoral fascias, bringing the shoulders back and down. So my pressure of my glide is coming across the chest. Take up all the slack. Now here we're going beyond just the skin. We're actually using a bit more compression to bring those scapulas down and back, bring those shoulders back out of that protracted and forward position. Where do you feel this pulling, Tommy?
Upper pec.
So he does feel it indeed in the upper pec, which is normal for this. If you're not comfortable crossing your hands, you can easily have your hands on both sides of the chest, and you can even see the movement of the pectoral fascias this way. Same release. If you wish to work unilaterally, you can have one hand at the anterior deltoid, one on the sternum, and have a nice stretch of the pectoral fascias this way. My hands are gliding apart, opposing one another. Now to check to see exactly what angle you should place your hands, I picture a clock on the front of a given area that I'm working on, and always viewed from the anatomical position. So if there was a clock at the front of the shoulder joint, we would have 12 o'clock, superiorly 6 o'clock, inferiorly 9 o'clock laterally, and 3 o'clock medially. So you can check the skin, moving 12 o'clock, 6 o'clock, superior glide, inferior glide of the shoulder, medial glide, and lateral glide, 3 o'clock, 9 o'clock. And you can also check your alternative angles around the clock. Now, all of his glide is fairly resilient and elastic, except for coming up towards about 10 o'clock. Feel the difference when I move this way?
Yeah, I do.
Okay, a little bit of tightness there. Now we notice there is some scar tissue here, and that may be part of the reason that there's some tension there. So I would line up that vector of tension, take up the slack in the way that is most tight, use my opposing hand for a counter force, and then just hold. And I could have checked to see, is there more traction or tension development at what angle of my hand, and indeed coming in this direction it develops the most tension. You want to line up the fascial tensions optimally so that you get the best release. You can also work for people who have, say, a frozen shoulder or tight shoulder girdle, bring them out to their direction of restriction in terms of elevation, supporting the extremity, and then using cross hands over the shoulder again that way, at whatever angle of elevation they're limited in. If it's painful to bring them up at that level, you can certainly bring them just 2 or 3 degrees below the painful zone, apply a slight distraction or a little traction, pulling on the arm as one force, and your counter force, your cross hand, could be at the pecs, it could be at the latissimus, particularly when it's limiting abduction or flexion. For people who have the forward head posture, you'll often find the platysma to be restricted, and especially the anterior lateral triangles of the neck. In this case, checking the fascia over the neck here, superior glide, inferior glide, a little restricted in the inferior glide here. So we may want to very gently have a little bit of lateral flexion rotation of the neck and cross hand right over that anterior triangle of the neck. Tell us where you feel the stretch.
Kind of like in my trap.
Okay, so he's feeling
Upper
it in the
trap.
upper trap region and over the anterior platysma. You could have easily just switch your hand position. You could get a little scapula retraction and depression at the same time, and you'll get some of the tension in the scalenes and upper trap also to release this way. So that's a great area to work for people with cervical fascial restriction. For people who have that drop chest, slumpy posture, they're slouching, you can use a cross hand over the sternal and abdominal region to stretch out the vertical fascial plane. in here, and have him work with some deep breathing. Again, taking care not to apply direct pressure to the xiphoid, but very lightly gliding the hands apart. This is a very superficial release. For rib restrictions, we'll test the tissue glide on an oblique angle, both sides. If it's tight on one side, just cross your hands, taking care not to put too much pressure on the ribs, but primarily to direct your tension between your hands. Feel some pull with this?
Yeah, I do.
Okay, so he should have more of an oblique pull through the chest. Again, very nice for people with respiratory obstructions, costochondritis syndromes, rib dysfunctions, any type of breathing dysfunctions, and of course the forward head posture. Okay, so now moving down the upper extremity, if someone has a flexion contracture at the elbow, especially patients with the high tone, you can use the cross hands over the elbow. One hand purchases the biceps, the other around the forearm, and simply distract at that level. This worked very nicely for those post-fracture dislocations. Once the fracture has healed, using a very light stretch, take up the slack and hold with the myofascial concept to open up the arm. For the palm, many people have restrictions coming through the flexor tendons and the fascias of the forearm relating to carpal tunnel syndrome, which is a compression neuropathy of the median nerve at the carpal tunnel here, right under the transverse carpal ligament. So you can get in here with your thumbs. We've done cross hands so far, but here we're just going to use thumbs. Apply a slight traction or pulling force, and then opening up that transverse carpal ligament, separating thenar and hypothenar eminences. To apply that fascial stretch, hold it for the 90 to 120 seconds until you feel the release. You can also add components of extension, a little traction, radial, or ulnar deviation to that. Line up the tension three-dimensionally and hold, and you'll get the best release. For people who are interested in neural stretch, particularly for carpal tunnel and repetitive strain injuries, you can also include working with the upper extremity using abduction, horizontal abduction, extension of the elbow and wrist while opening up the palm here, and you could even use a counter force from the shoulder or adding a component of gentle lateral flexion or rotation away from that side to increase the fascial pull and the fascial release through the entire upper extremity. Moving down to the lower extremity, for people who have hip flexion contractures, you may find when they've been, we'll hold this just here for a moment, you find they may be very tight over the anterior hip, rectus femoris, iliopsoas. So identify your anterior superior iliac spine and iliac crest. Use that as one hand position, and the second would be over the quad, just stretching out the hip flexors with a cross hand release. Coming down to the knee, people who have patellofemoral problems or post-total knee replacement, you may find there's restriction of the patella mobility, superior glide, inferior glide, medial glide, or lateral glide. In the event that the inferior glide is limited, I would use the web space of my hand to cup the patella, apply a very gentle stretch, and use my other hand as a counterforce over the quads. That's to initiate inferior glide. Take care not to force the patella because you can dislocate it if you're forceful. We're using only enough force to take up the slack and stretch the superior fascias of the patella. If the superior glide is limited, I'd use the same hand position but the opposite hand, web space, just under the inferior border of the patella, gliding it superiorly, and then a counter force over the tibial tubercle. So these are very, very nice, and you could adjust it for different angles depending on whether they have some ITB tension. I'll use more of an inferior medial approach and counter force on the ITB. That's especially for people with patellofemoral dysfunctions and a maltracking lateral patella rather than getting the surgical release. Over the anterior ankle, same thing. So if someone had a bimalleolar fracture of the ankle and now they lack plantar flexion, you can do the cross hands over the anterior ankle. For the cervical spine, you can use the cross hand or laminar release, applying a very gentle, for laminar release, cervical traction, working into flexion. Just take up the slack at the end of the motion barrier and hold until you feel the release, which will feel like a lengthening or a telescoping, axial extension, if you will, of the cervical spine. And that can be done in different degrees of rotation, lateral flexion, as long as the patient's comfortable and they don't have any dizziness, nausea, or unfavorable symptoms. You can even add a counter force with your opposite hand to stretch the lateral fascias of the neck here. Get that scapula down and back. Working more in lateral flexion. Feel the difference if that's tighter or is rotation more restricted. In this case, is lateral flexion more restricted, so that's the tension I would line up. And hold for my 90 seconds or whatever it takes to achieve the release. Same thing on the other side. Many of these techniques can be done in sitting, which makes it even more comfortable for the practitioner. Okay. You can also work through the plantar fascias of the foot. Rather than crossing my hand, it's easy to simply dorsiflex the toes with one hand and stabilize, or even a little bit of distraction of the calcaneus with the other, and you can see the direction of some of the fascial stretch coming through the plantar fascia of the foot. You can also do some cross finger stretch to the metatarsal arch. Very similar to what we did for the carpal tunnel in the hand. Take up the slack and hold. Muscle play is another technique that can be done. Instead of using a cross-hand technique or tissue glide, we're going to use an assessment of the play or the mobility of a given muscle group from its origin to insertion. Essentially using a kneading type of motion, lifting and moving a muscle transverse to its longitudinal axis from origin to insertion, or insertion to origin. In this case, the biceps would be stabilized at the forearm, and just see, can the muscle be moved laterally and medially relatively equally? Is the end feel elastic? And indeed it is. Coming up proximally, you can then check the pectoral fascias, which is a bit tighter here, but it gives you an indication of the mobility. You don't need to pick up the whole muscle to treat it. You can actually just access the border of the muscle, apply a fascial stretch, and hold, as so. Many people are restricted at the anterior border of the axilla, just where the pectoral and anterior deltoid come through. So I'll use my palm heel to get just under the border there, taking care not to compress the sensitive axilla or the nerves within it. So here I'll get the inferior border of that pec and deltoid, take up all the slack with a stretch, cradling the arm for support with my other hand. And you should just feel a nice soft stretch. Where do you feel this?
In the pec itself.
Okay, so he's getting a nice stretch in the pec. It's very gentle. And the muscle play is very useful, especially for people who have more acute situations, the tendinitises, the muscle strains, just to start introducing some movement to the area in a very gentle way. So hold that until you feel a softening underneath your hand, 90 seconds or so, whatever it takes, and follow the release. This works with the same concept of the clock. Check different angles to see which way is the muscle play most limited. In this case, coming up at this angle would be even better for him. And I could use different angles of the shoulder, abduction or external rotation, to access different angles of the pectoral fascias, moving up the arm. Especially for those flexion contractures, you can work the biceps. I'll form my whole hand over it, move it laterally, take up the slack if it's restricted there, and hold. Test the next level, all working from the medial border. Or, if it's restricted at the lateral border, take up the slack there and move it medially and hold for the 90 seconds or whatever it takes. And that should feel really good. Coming down to the forearm, people who have the tendinitises, lateral epicondylitis, extensor tendinitis, you can get in stabilizing radius and ulna and just feel for the extensor wad. It is generally tighter because the fascia are more closely held to the ulnar border, just as in the lower extremity the fascias are held more tightly at the lateral and peroneal border. Now here, he's a little bit tight right here, so I will take a purchase on the entire muscle mass, move it internally, almost picturing as if you have a long bone and you're spinning the muscle either counterclockwise or clockwise, as the case may be, around that bone. This feels very good for those people with the repetitive strain injuries. Just to hold. How is that?
That feels great.
He's happy with that. It's a good thing. Okay. You can use some of the same technique coming down to the lower extremity. I'll just roll this up to access the quads. Especially post-surgery, once these scars have healed and matured, you can check the muscle play, vastus medialis group, rectus femoris, anteriorly. And here just using a pincer grip with the pads of my fingers to isolate different muscles, check for the play. Often I'll take the entire extremity, stabilize it on my shoulder, bend at the knee, and using a circumferential grip, almost like turning a steering wheel clockwise or counterclockwise, get a purchase on the muscles using my palm heel at the iliotibial band border and medial hamstrings to take up the slack and hold, almost as if rotating, in this case, counterclockwise. Test the muscle play through the lower extremity. You find an area of tension, take up the slack there and hold. This also feels very good for people with that iliotibial band tendinitis, tightness of the ITB, piriformis syndrome, etc. And you can also work from the hamstrings medially. I'm using a clockwise motion, take up all the slack and hold. For the tight gastroc and soleus, I would stabilize the foot with my leg. Identify using this type of a grip, medial and lateral head of the gastroc muscles, clockwise, counterclockwise. I'm testing lateral motion, medial motion, and moving down the whole area. I feel an area that's restricted, take up the slack in that area and hold. This also works in different positions. Supine is just one idea. You could certainly do this in prone, or if you can have a good purchase on the entire muscle belly, you can stabilize with one hand and perform your release with the other, always having a counter force or stabilization. To do muscle play on the posterior surface of the body, if the patient isn't prone, it gives you nice access to that tight upper trap that everyone has. I get a purchase of forming my hand and making sure I'm melding my hand to the entire muscle. Using just the fingertips can be pinchy and quite uncomfortable. I'll form the hand over the upper trap, in this case moving it anteriorly, posteriorly, coming just above that superior spine of the scapula, and test the muscle play of the upper trap over to its insertion at the acromion and the clavicle. And here he's got pretty good muscle play moving anteriorly, but posteriorly a little bit tight. So I'll take up the slack there, stabilize the scapula, apply my myofascial stretch, and wait for my tissue creep and my release. That should feel quite good.
Yes, it does.
You could even do a counter pressure here, and add a little cross hand release to the muscle play at the same time if you wish. You can also come from the posterior aspect of the neck, almost like a dog would carry her puppies. Get a purchase on the posterior rectus spinae and fascial tissues, lift, moving to the left and to the right. I'll tend to do my release for the left side, from the left side of the body, taking up the slack, and you should get a nice stretch through here. Stabilizing with my other hand, and you can work your way down, just getting the border of the muscle. It's not necessary to pick up the whole muscle, but you could release from the border of it, or with two hands, lift up very gently, and feel just the general muscle play in the extensor mass of the neck. Feel a little tension, particularly inferior aspect of his neck, take up the slack and hold. For the paraspinal muscles, because they're not as cylindrical, a little bit harder to access with a full grip, I'll use either the palm heel or fingertips to test from the medial border, where you have spinalis, comes off of the spinous processes, just lateral to the spinous processes, and I'm feeling for that depression between the spinous process and the muscle belly. And I'll test that using the whole border of my hand from the thumb all the way up to the CMC joint. And again, some of the tightness we identified earlier is evident in the mid-thoracic spine, a bit more resilient here, and more resilient into the lumbar spine. I could use my palm heel, take up the slack, similar to the laminar release, but going deeper to access the muscle border and hold. And that should feel very, very good, especially for those acute backs, or if you have tremendous spasm in the back, you'll get a fantastic release with this. While he's prone, we can access the triceps. So again, same type of release, test the muscle play through the muscle, stabilize, take up the slack, and hold. Coming down to the lower extremity, we'll just check out the hamstrings on this side. You can test the muscle play of the hamstrings either as a group, stabilizing the knee. And he's tighter in the lateral border. So good muscle play coming laterally, but medially a bit more restricted, which is typical because that IT band is a tighter fascial plane than the hamstrings. You could even identify individual hamstrings, in this case medial hamstring play. You could take up the slack and hold to stretch out, or laterally, the same thing. Coming down to the gastrosoleus, I'll support the ankle, and you can access the medial head of the gastroc, or the lateral head, or the entire muscle belly, and use almost a torsional twist to take up the slack and stretch those muscles. That works also very nicely on those taut Achilles tendons. Take up the slack using the calcaneus as a lever or a counterforce, and stretch that Achilles tendon. What we'll be exploring is called circular friction, and that's a technique that's modified from something called ametherapy, which is an oriental acupressure treatment, massage using circular strokes that can be done with the fingertips or thumbs, or if you wanted to get deeper, you can use a thumb over thumb position, or even break out your elbow and start working with your distal humerus, proximal ulna, or olecranon. These techniques are particularly useful to separate the fascial attachments and adhesions that form between layers of muscle bellies. Also, at the muscle attachments, origins, insertions into the periosteum of the bone. Gets you an excellent release. It's something that you would like to educate the patient ahead of time, different from the myofascial releases we did this morning. It's more of a deep tissue mobilization, using a deeper pressure almost to dissect out those areas of insertion where you tend to have muscle adhesions, cross fiber restrictions that develop, and fascial restrictions. It will feel very deep in terms of the pressure. We'll start superficial and work deep, and we let the patients know it may actually be a bit uncomfortable. If it's too uncomfortable, then it's important for the practitioner to back down the pressure and go lighter or select another technique. It's also important to educate the patient that possibly the next day they might have a slight delayed onset muscle soreness, similar to when someone has a new workout. And you may instruct them to use whatever you would ordinarily recommend, such as ice or gentle range of motion therapy, etc., to relieve any soreness that may occur. Now, to achieve depth in tissues such as the low back, many people don't achieve much depth in here with traditional massage or stretching techniques. I'll use a hand over hand position such as this so that I can use my body weight behind me to get deep pressure into the tissues. And notice the patient in this case is side lying with the knees bent up significantly above 90 degrees, or at least 90 degrees of hip flexion. That will prevent him from rolling around on the table. You want good stability. You could also stand such that you are in front of his knees, blocking the knees so that he can't roll off the table. Now, for those of you who haven't been down here in a while, the spinous processes are the most midline bony projections that you can identify in the low back. The iliac crest, if you feel for the most narrow part of the waist with the web space of your hand, push in and down. You can feel the superior border of the iliac crest, at which many of your lumbodorsal fascias insert, your rector spinae muscles, quadratus lumborum, etc. There are even connections into the upper extremity through the latissimus dorsi, which also comes into the lumbodorsal fascia, and of course into the iliac crest. So you can use your circular friction moving from medial to lateral, just at the upper lip of the iliac crest, and I'm using hand over hand and using my body to do the motion. You'll see you don't see fingers moving and wrists, locking up the wrist and fingers, locking up the forearms and elbows, and using a shift of my body weight, leaning back to get compression, and making a slight circle by shifting my weight from one leg to another. So I'm always operating from my own center of gravity and not straining my hands. And if you're doing this for a while and someone who's very tight, you may find you want to change your technique such that you're not making your fingers tired. You can actually use your distal humerus and start stabilizing from his back here with your other hand And using a circular friction stroke, you can access the deeper tissues, moving up the erector spinal muscles. How is this, Tommy?
That feels great.
He likes the deep work. It doesn't matter if you go clockwise or counterclockwise, just work into the tissues at whatever level the patient's relatively comfortable and you're comfortable. A little tighter out here at the quadratus.
Yeah.
Is that okay?
No, I'm fine.
So check to see too, if you're using a circular friction on a very active trigger point, if it's too painful, you might want to move a little bit medial to that area and work it out, a little lateral to the trigger point, superior, inferior, all around it. So you work from the periphery of the trigger points in. Don't force a circular friction over a painful trigger point. You'll just set up resistance in the muscle and discomfort on the part of the patient. You can equally approach this aspect of the body from the posterior surface. I can be behind the patient using a thumb over thumb technique, keeping my wrists relatively neutral and using more of a point pressure with the thumb pads to access some of those deeper muscles. Here the most medial muscles next to the spinous process are going to be erector spinae, spinalis, and here I'm coming between the spinalis and the longissimus muscles. So you don't want to be circular frictioning over the muscle, but look for the spaces, the nooks and crannies, if you will, between the individual muscle bellies. If you're coming more laterally, you'll be between longissimus and iliocostalis. So rolling over it like this is not what you want. You want to get into those depressions between the muscle bellies, almost as if you're opening up a set of curtains, separating the muscle bellies from one another. And someone who's more frail, you'll use a gentle technique. You might only need to use one finger or fingers over fingers. Here's a little quadratus action here. Or you can get your thumb in there, stabilize the pelvis, and you can work shifting your body weight forward for the compression and making your circular friction. Taking care to keep your elbow below the shoulder level so that you don't give yourself an impingement. You can also work up the body that way. I'll work slowly in an area that's tight, but you can work up with your circular frictions up the entire spinal muscles. And here we can palpate some areas of fibrosis, interestingly right where we were tight on our initial assessment before. You can work up into the scapula and watch the positioning for this. Bring the humerus to a neutral position anatomically, and if you lace one hand underneath his arm, you can see how nicely that inferior angle of the scapula is accessed. With your other hand draped across the acromion, you can very gently test some of the motion of the scapula, protract and retract, inferior glide, superior glide. Nice way to warm up the tissue, and usually very comfortable for the patient. And holding that position with a little bit of slack, dropping that arm back by pushing the acromion posteriorly. This way you can see the scapula border becomes more prominent, and I can get in there with my circular frictions and actually work at that subscapularis. Feel the depth here?
Yeah.
At the anterior border of the scapula. Work your way.
Really good, man.
Feels really good. So we like the editorials are good. Always make sure you have those editorials going. The patient's telling you how they feel. To access the superior medial border of the scapula, shrug the shoulder up a little bit passively. Get that levator scapular attachment right in here. That's often a very sensitive area for people. So I'm using just the fingertips here, working into the upper trap and supraspinatus, supraspinous fossa, etc. You have someone with a rotator cuff problem, you keep the arm in neutral, and you can work that entire area just with gentle fingertips, getting into that greater tubercle, those rotator cuff insertions, coming a bit lighter over the anterior border because you have the sensitive bursa, bicipital tendon, etc. Circular friction also works great working up the traps into the cervical spine. In this case, I'm stabilizing the scapula and using that friction, just working up the trap, staying off of the trigger point, working just around it, in between the fascial layers, and only at the depth that the patient will tolerate. This is something that naturally is contraindicated on people who are too frail or on blood thinners such as Coumadin or heparin, anticoagulants. And how good does it feel to get underneath that occiput, stabilize the head, Get in between the suboccipital muscles, upper trapezius insertion, splenius insertion, in between the nuchal lines of the cranium. Should feel very, very good.
Oh, yes.
Oh, yes. So you can also work into that lateral epicondylitis using your circular friction between the extensor digitorum and extensor carpi radialis muscles, or between the extensor digitorum and extensor carpi ulnaris muscles, as opposed to working right on the muscle itself. So this is rolling over the muscle. See, he has some taut bands in there. So I'll go between them in very small circles and separate those muscles from one another to enhance the glide of the muscles past one another as they contract individually or together. It can also be used on the lower extremity. As a matter of fact, you can use it anywhere where muscles are attaching, origins and insertions, to break up adhesions that develop commonly at the attachments of the muscle, the musculotendinous junction. And here for the ITV, which is commonly very tight, I'll use my circular frictions coming down the anterior border, which means you really need to have a good knowledge of anatomy and good palpation skills to be able to feel where these muscles access. Is this okay for you?
Yes.
Many people are very sensitive at the ITB, especially the most lateral border, so work just ahead of that. I also tend to work primarily distal to proximal or following the circulation if someone is having a problem with edema. You can even get a little muscle play in there at the same time. So I'll often work the circular friction and the muscle play together, alternating. If they get a little bit tender from the circular friction, alternate with some muscle play to release some of that tenderness. How about those shin splints? You can work from the shin up, getting into those anterior tibialis muscles. And this could be just some fine thumb work. The shin splints are characterized by strain of the anterior tibial muscle group, the extensor muscle group, and sometimes the peroneals, and is commonly involving a periosteal fascial fracture where the tissues insert into the periosteum of the bone. So something you can get in there with the nice circular friction, alternating my hands so as I don't get too tired with one or the other, or even the knuckles can be used through and neutral wrist. Very important. Protect your hands. Much of this work is deep, and you want to last a long time. Okay. For the respiratory diaphragm release, we'll be working with the fascial attachments of the respiratory diaphragm along the inferior border of the ribs, where also we have attachments, of course, of our abdominal muscles, including our obliques, transversus, etc. Now, to palpate the respiratory diaphragm, you can't actually get the depth, but you can test for restrictions that may have an impact on preventing full elevation of the ribs by palpating the inferior border of the ribs here with a very soft hand. When you approach the patient, you should be at approximately a 45-degree angle with your hand, taking care to identify where the xiphoid process is and to absolutely avoid applying any pressure over the xiphoid because it may fracture. Now initially, palpate the breathing of the patient to assess the rib mobility side to side. Do both sides elevate symmetrically and depress symmetrically? So we'll look for the bucket handle movement of the ribs. Take a nice deep breath in a few times. The ribs normally move up and out and down and in, just like the handles of a bucket. And you're palpating to see, does it elevate more on one side or fail to elevate on one side? You can also take a circumferential measurement of the chest at full inspiration using a tape measure to detect the respiratory excursion before and after the respiratory diaphragm release to document functional outcomes. If you have an incentive spirometer, that can also be used to document the volume of air coming in before and after the respiratory diaphragm release. Orthopedic measures that would show how the respiratory diaphragm release benefited the body would be if the tightness in the attachments to the ribs is due to some of the fascial structures of the flexor muscles, you'll find that spinal extension will be limited. So measure goniometric spinal extension before and after the respiratory diaphragm release. If he has a restriction that is unilateral, such as on the right side, it will limit lateral flexion away from that side. So you can use goniometry to measure that as well, and it may limit rotation to either side. So let's test one side. Palpate from medial to lateral using almost a supination type motion and the very tips of your finger pads. Do not go in with pointy fingers because otherwise you'll end up nailing the person with your fingernails. Needless to say, you can't be wearing sharp jewelry or using long nails to do these techniques, unless of course you're licensed in acupuncture. So palpating, if he has any tender points here, any areas where my fingers won't easily glide underneath the ribs, that would indicate a restriction. I may come back to that area, make sure the patient has his knees bent, bend your knees, put your feet on the table, and I'll support him with some pillows there so he can be relaxed. Have the arms down, because if the arms are up, you'll see the fascia become tighter again. So here, and nothing too significant here. I can get my fingers curled under, a little bit of tension right here. Any tenderness here?
No.
So to do the release, I'd apply a very, very soft, meaning the weight of my hand, compression to the ribs on that side, and then press posteriorly, inferiorly, and laterally. Just with the weight of your hand to stretch. He should feel a tiny little stretch under my fingers.
A little bit.
Very soft. So the weight, you won't even see the fingernails blanch on your hand because the weight should be that light. As you hold that for 90 to 120 seconds or so, you'll start to feel your fingers sink into the tissues almost by themselves, almost like sinking into jello. So it's very, very light. And the objective is really to show that you can use a very, very light technique in order to achieve depth of penetration to the tissues and to achieve a change in the fascial structure. So we'll do that at whatever level of restriction we find along the way, and then test for tender points again at the finish of the treatment. I'd also ask the patient, take a deep breath in, feel the difference from before and after on your inspiration. Now the iliopsoas is the next release, which also shows how you can use actually very light pressure but achieve a great depth of penetration into the body. So again, these use the myofascial concept. These are very, very gentle. If you force these areas, you will irritate the body or possibly traumatize the tissues. Let's start with the legs down flat, and let's identify where the iliopsoas muscle is. The iliopsoas muscle originates, and we'll just look here from the spine, from the vertebral bodies of the lumbar vertebrae, intervertebral discs, and transverse processes, and it comes down to meet the iliacus muscle that lines the internal bowl of the pelvis, and the conjoined tendon passes just anterior to the hip joint. So you can palpate the tendon, where we will do a muscle play type of myofascial release, just at the inferior medial border of the ASIS, anterior superior iliac spine. You can notice just above the hip joint itself, if you feel on yourself, the ASIS, right above the break in your hip, come to the inferior border, and we'll find it on the patient, and medial, and flex your hip up to feel that muscle contract. Let's find it on our patient. Now, because, again, the abdominal area is very sensitive and often very ticklish, approach with a flat hand. So you can feel the bony projection of the ASIS. I palpate it right here. Here is the superior and inferior border of the ASIS. So have your fingers inferior and medial, and ask the person to lift your leg up for me. And release. Feel that tendon pop under my fingers? And it's nice to show the patient also so they understand what you're working on. And this is one of the muscles that comes from your back and helps to move your hip and your back. So if you have a problem with that muscle, you may find goniometrically there is limitation of hip extension, which should be reduced, and you should have a greater hip extension after this release. Now lift up your leg. Feel it jump under your finger and relax. So now he's identified this muscle. Many indications for this would be anyone with back pain, people who have limited hip extension for any reason, be it a high tone problem with joint contracture, or someone who, when ambulating, fails to get good hip extension and they end up hyperextending their back as a compensatory pattern. You want to reduce some of that back pain by lengthening the psoas. So here, let's find a tender point. Any tenderness in here? How about compared to here?
First area was a little more tender.
This one's more tender. So I feel some taut bands in here. It feels like you can play guitar in that muscle. What number would you give that pain on a scale of 0 to 10? If 10 is extreme pain and 0 is no pain.
7.
That's a 7 out of 10. So always check your visual analog pain scale on a scale of 0 to 10. How much does that hurt? Check that before and after the release. So I've identified the tendon. I'm now going to use a combination of something called counter strain, which was developed by Dr. Lawrence Jones. And that involves bringing the hip passively to about 90 degrees or a little bit above. and holding that position so that the patient does not have to hold his leg at all. It's completely passive. I'm still palpating the tendon here, just medial and inferior to the ASIS. I'm going to apply a little pressure to the border of the tendon, like muscle play, take up the slack where it was tense. Any pain?
No.
How much pressure do you think I'm putting on you?
Minimal.
Minimal pressure. So the pressure is very gentle, and I'll simply hold this release for 90 seconds. Now you don't want to do a half of a psoas release, so wait until the pain is reduced at least 50% before releasing the tender point. Otherwise, sometimes it tends to become a bit more aggravated in my experience. So we'll hold this point right here. Now, while we're waiting for this muscle to relax, focus on breathing into your belly. So you're going to teach the patient some diaphragmatic breathing exercise. Very soft. Feel that the breath comes more in your belly, not so much in the chest. Now, I'm monitoring the point here, and I could again imagine the face of a clock over the hip joint or over the very tendon that I'm putting that myofascial muscle play on. I can move my muscle play to a 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock, see which direction around the clock has the greatest fascial tension, the greatest vector of force, and that is the direction that I'll apply my pressure very softly through my straight fingers, just medial to that hip. I'm getting a little release right there. Feel a little depth. I can now sink my fingers in. What does it feel like?
A little softer.
A little softer. Okay, so I got a release there. Typically I'll do 2 or 3 releases in a given area and reassess, but I'll give you time to try exactly that. Take the patient out of the position very slowly so as not to cause any stretch reflex. Allow him to come back down into neutral very gently. Now, I have not moved my hand. Check again. Any pain?
No.
No pain. Check again. Go to that other spot that hurt too. Okay, so in 90 seconds you can eliminate trigger point with a very, very gentle technique incorporating positioning with myofascial muscle play. Techniques that we'll be looking at are moving away from the light pressure and again towards the deeper pressure. So here we will be using some lubricant. In this case I've selected some Biotone massage lotion, deep tissue lotion, because it doesn't spill out of the container when you turn it over. You want to have a nice tacky lotion that gives you a good glide without slipping off the body. So the first thing I'll do is distribute the lotion over the area upon which I want to work with some light effleurage strokes, and then working with the deeper strokes, we're going to use longitudinal deep stroking, in this case using the tips of my digits of my fingers, the long effleurage stroke down the back. We're using this as an assessment technique and as a way to warm up the tissues. So it's a general massage stroke. You can also use your thumbs to do the same thing over the tissues. However, you're taking care to apply the fascial concept of wanting to be between the muscle bellies. Not on the muscle belly, but feel for the interdigitations between the tissues so that you're separating the fascial layers of one muscle from another. And as I'm coming down the back, I'm feeling for areas of tension. I'm palpating for what I'll call bumps in the road. And I can even get deeper pressure using a hand over hand, similar to the way we did our circular friction. And the indications for this Z friction that we're going to do are the same as for the circular friction. Works very well over muscle attachments, origins and insertions. Works very nicely between muscles to open up those muscles and separate the muscle bellies from one another to allow them to glide more normally. You can even use a forearm to warm up the tissue in this manner. And you can get more depth because you can get your body weight behind you. And then you can even start to bend your elbow and get your olecranon stroking in between those muscle layers. It's a little tight right in here. How are you doing?
Okay.
So use the depth of pressure that the body will allow you in. If they start to have pain, if the pressure is too much, lighten up. Especially when you go over bony prominences, you definitely want to lighten up, as this is to be used between muscle bellies or at the attachments. So now if I feel areas of tension, what I'll call bumps in the road, you feel that you can't get a nice smooth effleurage stroke through, you'll now take the stroke and change it into a Z. Coming down the back, he has some tension here, I'm going to move in between those fibers. See, this is over the fiber. See the jumping? That's not what you want. In between the muscle fibers, smoothly with a small Z, a small transverse friction stroke. But the difference with this is that you are constantly moving. You don't continually stay in one spot as in the traditional transverse friction. To do so will typically be noxious to the area, painful, and the person will be tightening up as a result. So Zing all the way through, insertion to origin or origin to insertion. You can use the fingertips, come down, feel an area that's tight, and get your Z's moving. Constantly in the nooks and crannies, between the bellies. How does that feel, Tommy?
That feels very good.
Okay, again, the angle of the muscle changes here, and I'm just going to follow that. And work deep. This is a great way to get deep into the tissues and break up those adhesions. Make sure to do a complete stroke and finish all the way through. To work the elbow, I wanted to work up the back. Apply a little bit of lubricant to your forearm and elbow, making sure that you understand there are three parts of the elbow. You have the very pointy olecranon, which is a bony prominence that is rather sharp and deeply penetrating. You can use your broad proximal ulna or your broad distal humerus to access the tissues in a more soft way. So when you're first introducing, use a broad surface, and then as you want to get into the deeper tissues, I'm using my olecranon. Now here, if I wave goodbye to the restriction, I get my Z moving through my olecranon. So a slight internal external rotation of my shoulder while I'm working up between the muscle bellies using my elbow. Find an area that's tight, slow down in that area. Give it the chance to release. How is this area here, Tommy?
It feels good, but it's tight.
Okay, so he can tell we're both in the same area. We understand it's tight. There, see we flicked over the muscle. To avoid that, get your web space of your thumb and index finger to guide your elbow to keep it from slipping. Many people don't have a good proprioceptive sense using their elbow initially, but with practice you will definitely develop that. So you could work that right up the back and just finish the area with a bit of effleurage just to milk away any fluid. Now you can stay and do the same techniques up here for your upper trap, moving from insertion to origin, using the thumbs, or in someone who is not as muscular, you can use a single thumb. Work right through that area. You find that tender point in the upper trap, go just distal to it, work around the periphery of the tender point. Same thing with the posterior cervical spine, get in between those spinal muscles, right up to their attachments. So you can Z your way through that whole area. Works very nicely. Okay, you can continue with the long effleurage through the back of the leg, and the same type of strokes apply to the arm. Distribute your lubricant first to break down the resistance of the tissue between your hand and the skin, and now you do just to the lateral and medial side of the Achilles tendon, longitudinal stroke. And here's a bit tight, particularly on that lateral border. Come up to the musculotendinous junction, follow the muscle tissue. So you need to really sense where the muscles are, taking care not to put deep pressure behind the popliteal fossa, and you can work your way up between the medial and lateral hamstring muscles, all the way to the origin of the muscles. Come up right through the middle of the gastrocsoleus. There's a little bump in the road right here, and I can start my Z. I'll generally do a few minutes of the longitudinal stroking first to warm up the tissue, distribute the lubricant before starting my Z stroke. You can think about that when you're working with a partner or with a client. How does this feel, Tom?
Feels very good.
So we're just getting the medial side of the lateral head of the gastroc. And make sure to the fascias are continuous up through the entire back of the leg, so you want to work all the way up from the heel to the gluteal region. Fingers get tired, thumbs get tired, switch, use your fingertips. All the while making a Z, separating those muscles from one another, coming back down. You can even make your Z up in this direction just by flexing your fingers with the counter pressure like so on the opposite side of the leg. Much easier for you. You can actually work two sides at the same time. You Find an area that's a little tight, spend a little bit more time there, slow it down, but don't stay in one place for too long because it will tend to become very sore. It's especially nice at those tendons behind the knee. Both sides, separate those semitendinosus, semimembranosus tendons behind the knee. It's got a little crepitus back there, which is also showing there may be a bit of a restriction in that area. So you're feeling for the spaces between the muscles and Zing your way through, insertion to origin. And effleurage at the end. Now you can work with the Z friction and the long effleurage strokes, especially for those repetitive strain injuries, those tendinitises of the arm and hand. And that would be identifying the extensor muscles, moving from the radius. You see actually a little restriction there already in some of the thumb abductor muscles. So long effleurage along the radius, going up to the lateral epicondyle. And feel for any areas of tension here. So that, again, it's an assessment stroke, it's warming up the tissue, and I'm feeling now between extensor carpi radialis and extensor digitorum. And from the other side, the extensor carpi ulnaris and the extensor digitorum muscles. You can see the line between them. You want to be able to palpate that. Now, I found areas of tension. You're going to make a very fine Z because there's very small space between these muscles. So you could use your thumb or your fingers and just make a very fine Z as you're moving proximally, bringing the circulation with you as you're opening up those muscles. Switch hands frequently. I know many of us are one arm dominant. It's very important to start to learn to use these skills on both arms bilaterally, A, so that you don't end up with a repetitive strain injury, and B, to really maximize your effectiveness of working two-handed on the body. I mean, really covering a lot of a larger area. So you can get some Z's into the flexors, in this case between the brachioradialis and the flexor muscle mass, etc. Okay, so if you've been into the initial part of part 2, you had a chance to see some of the cross-hand releases, which is a variation of something that John Barnes frequently teaches. Cross-hand releases basically use your hands in opposing motions in order to stretch the tissues. Laminar releases are when you use your hands pushing in the same direction or pulling in the same direction to achieve a release. Which is more correct to use? Neither. Check to see how your hands fit on the body, or your knuckles or your forearms when providing the stretch. And remember that with a cross-hand release, we're stretching with opposing forces of two hands. So we don't really need a counter force. Our hands are their own counter forces. When using a laminar release, we're stretching tissues in one direction. The body's weight acts as the counter force. You can also adjust your pressure or tension according to the needs of that restriction. You need to practice really testing the tissues three-dimensionally. When you're working on the body, think of the face of a clock anywhere you're working. And when you start with your tissue glides, think about gliding the tissue up till 12 o'clock, 6 o'clock, 9 o'clock, 3 o'clock, 10, 4, 2, 8, all around the clock, and see which direction does the tissue fail to move. Say it doesn't move too well towards 10:30, but in all the other directions you have a nice amount of tissue glide. Your release will then be done by stretching the tissue up in the 10:30 direction. Holding it that 90 seconds or so until you feel a softening, a lengthening, and as your hands start to glide again with that tissue creep, you can take up the slack and do a new release again, or you can gently withdraw your hands, reassess the tissue, and see if more release needs to be done. Now, moving from those tissue glides, those are surface releases. You can do the skin rolling where you lift up the skin and roll it in different directions and see, is it tight in any one direction? The direction that it's tight is the direction that you'll be applying the stretch using skin rolling. As you move into muscle play, you're lifting up the muscle and stretching it away from its neighboring muscle. Check to see what is the play like, moving laterally, moving medially, for instance, with that given muscle. If you find there's less play moving medially and there's an abrupt stop to the motion, no elasticity at the end of the motion, that is a restriction, and that's the time for you to take the opportunity to take up the slack, pulling that muscle belly medially to apply a stretch. Now, some muscles you can grab with one hand. Others you need to use two hands, or on little people, tiny fingertips to work that muscle play. The key is check the quality of the motion and the quantity. By the quantity of motion, see how much the tissue moves. Is it equal in all directions? Is it equal left to right? Then, as far as the quality goes, bring that tissue to the end of its range of motion, apply that stretch right against the motion barrier, and hold it. At that point, if you oscillate gently against the motion barrier, normal tissue will feel elastic. There will be some bounciness to it. Restricted tissue will have an abrupt stop to the motion. You will not feel that elasticity. It feels like you're up against a brick wall. That's a restriction. That tells you go ahead, gather up the tissue, take up the slack against that brick wall, and hold it until you feel that softening, that release. And although we recommended that 90 seconds is the clinically documented average time for a release, I've waited up to 20 minutes for some releases. And believe me, they were worth it. But average, if it's taking you more than a few minutes, probably like to reorganize your hand position, your pressure, or maybe try a different technique. Now we're going to be moving into some deeper techniques. Deep circular friction. Deep circular friction is just as it sounds. We're making circles and we're going very deep in the body tissues with a friction type of stroke. Looks and feels like a massage stroke, but it is highly precise compared to general friction massage. As you may recall, transverse friction massage uses motion completely repeated in one area, usually at 90 degrees to a muscle tendon and right over the fibers. And that's great work, but that's not what you're here to learn today. Today we're going to do circular friction, which has the same depth as transverse friction, but we're going to be making circles in the fascial planes between the muscles or within an individual muscle. Remember that muscle bellies need to glide past one another when they contract. If they develop adhesions between them, they may stick together, and you'll see compensatory motion patterns. We'd like to restore that tendon glide, that muscle glide between layers of muscles and within individual fascicular compartments of a given muscle. So you can palpate with your fingers, and I recommend work from insertion to origin toward the heart, applying the circular friction gradually from insertion to origin. Feel for the layers between those taut bands of fibers and applying the circular friction using your thumb or fingertips or knuckles or, yes, even the elbow, depending on how tight and how deep those structures are. Now, mind you, this might be a little sore for the patient. So if there are multiple trigger points or tender points in the area, I do not recommend using this technique right away. I only use it according to the tolerance of the patient. The other aspect of this is if you're doing a deep technique like circular friction, prepare the body first. Do some tissue glides, do some cross hand, maybe some muscle play or other modalities to relax the tissues first and get the tissue ready for this deeper work. The circular friction breaks adhesions very effectively, but it can be sore and should be followed if indicated with ice, liniments, and exercise. We're breaking those adhesions that occur in the fascial planes, and you'll see a nice improvement in mobility when using circular friction. Remember to apply it to both attachments of the muscle, the origin and the insertion, and then strip through those layers of taut bands within and between muscles with your circular friction. Protect your hands by switching right hand to left hand, sometimes the thumb, sometimes the fingertips, sometimes the knuckles, or the elbow to get those deep, tight structures. This way you're protecting your own body and you won't harm yourself. Now, we started our techniques with some very gentle work, such as the tissue glides, the cross hands, the muscle play, and I recommend that you perform the myofascial work in the same sequence on your patients. Once you've done the light work, then you can proceed to some of the deep circular friction to get into those really deep layers and those very taut adhesions. But sometimes you need to work very light, and I'd like to promote the next two techniques as an example of how you could work with both direct and indirect technique, how you can use the gentlest of pressures to actually access very deep structures in the body. Let's look at two particular releases, the respiratory diaphragm and the psoas release, and see exactly how we can get deep into the body using very, very light pressure, like just a few ounces, over your fingertips. If you think about the respiratory diaphragm muscle, it's a dome-shaped muscle that has attachments or insertions all along the lower internal borders of your rib cage. Some of the insertions extend all the way around the posterior ribs as well and right into the spine, actually as low down as L2. That cruce of the diaphragm goes down that deep. We'd like to be able to work on restrictions that may affect the respiratory diaphragm by performing little muscle plays at each of the diaphragm attachments around the ribs. Who might need this technique? Well, of course, anyone who has restricted ventilation may benefit from this technique. In people who have chronic obstructive pulmonary disease, for example, or asthma, improving the breathing is always an excellent goal. But what about people who have injuries to the ribs or strains of the diaphragm? Car accidents with seat belts that crush the ribs? What about the people with the scoliosis that have the ribs compressed on one side where the ribs are depressed? The side of the depressed ribs are typically restricted and don't allow normal ventilation of the pulmonary bases. How about the football player that goes out running with his ball and somebody goes whack right in his ribs and he's sore? If he doesn't have a fracture and he's cleared to come in for the myofascial, you may find that he has some abdominal oblique or respiratory diaphragm restrictions in that area. So we can use this technique to improve range of motion. Because if someone has a trauma or a tightness on the side of one rib, think about what motions will be limited. You can measure spinal goniometry before and after respiratory diaphragm release, and you'll see a nice measurable change. A restriction in the right anterior ribs will limit extension of the spine, lateral flexion to the left, and rotation in either direction. So you have a nice way to objectify your technique. Clearly, ventilation can be measured before and after the technique using incentive spirometry, using even a tape measure just to measure the excursion of the thoracic cage during maximum inspiration. It should be a bit larger after the technique because you'll have greater excursion of the ribs. To keep it very simple, you could simply palpate the ribs on both sides and feel for symmetry of that normal bucket handle motion of the ribs. The ribs that don't elevate may be the side to be indicated for the respiratory diaphragm release. In doing this release, we'll palpate the lower internal borders of the ribs with our fingertips. Make sure the patient is in a relaxed position, not hyperextended at their trunk or hips, because that will put a stress on the abdominal obliques. You want to make sure that they're lying flat on their backs or sides with some pillows under their legs, knees bent up toward the chest, and some pillow supports under their heads. And this way we eliminate the flexor tension of the abdominal muscles. We could get deeper to the respiratory diaphragm. Palpate the lower borders of the ribs and see, are there tender points? Are there areas where your fingers can't gently curl under the ribs? In that case, we're going to do a take up the slack and hold technique, gently pressing your fingers there with a few ounces of pressure and doing the little clock assessment. Does the tissue move medially, laterally, superiorly, inferiorly, all around the clock? Which direction is tightest? Take up the slack in that restricted direction and hold it for the 90 seconds, 2 minutes, whatever time it takes. As the tissue softens, your fingers will gently sink underneath the ribs. No force should be utilized here. Very, very gentle pressure, usually less than the weight of your hand, will achieve an excellent release. And in terms of some contraindications, a few additional contraindications to this work would be pregnancy. We do not work on the bellies of pregnant ladies with these techniques, partly for medical legal reasons and partly to make sure that we do no damage to that developing child. Anyone who has conditions involving the viscera or the abdominal region that you don't understand, maybe they have diverticulitis, infections, hepatitis, any number of conditions, you would stay away from those unless you get medical clearance. Some people have medical hardware that remains internally after their surgeries. I would not care to be moving around medical hardware. It could be staples, sutures, mesh work done to repair hernias. So before investigating either of these techniques on a patient, thoroughly get the medical clearance to do so. Now the second release, the psoas release or iliopsoas release, is done in a similar manner to the respiratory diaphragm. And these two releases should be examined together because the fascia of the respiratory diaphragm interdigitates and connects with the fascia of the psoas. So remember to check both of these as we go. In a similar manner as the respiratory diaphragm release, we can do a psoas release. It also utilizes very light pressure of the fingertips, but we're going to access the iliopsoas tendon as it crosses the hip. Remember, we're going to take up the slack and hold where the tendon is tight based on our palpation, wait the 90 seconds, 2 minutes, or whatever it takes, and do a little muscle play on the tendon of the psoas. Now, if you think about reasons to do a psoas release, clearly someone who has tight hip flexors would be indicated for this. You can measure the normal goniometry of hip extension to determine that, or do an orthopedic test called the Thomas test. If someone has a lot of sedentary behavior, maybe they're wheelchair bound, maybe they're some of your geriatric clients in a nursing home who sit for prolonged periods of time, they tend to get tight hip flexors. How about your patients who have spasticity of the flexors in their legs? They tend to develop joint contractures of the hip flexors, and these people would be primary indications for the psoas release. Since the psoas is a back muscle, think about where it originates. Lumbar spine anteriorly, intervertebral discs, transverse processes, comes down bilaterally to meld in with the iliacus muscle that lines the internal bowl of the pelvis. The two muscles come together to form a conjoined tendon right in front of the hip joint. So if you palpate on yourself your ASIS, anterior superior iliac spine, palpate that now. Then bring your fingers a little medial and a little inferior to the ASIS. If you curl your fingers inside the ASIS, you can feel the firmness of the bone as you push laterally, and you can rub up and down and feel the tendon of the iliopsoas muscle as it passes the hip. Frequently it feels like a taut band, and very commonly it is tender. To make sure you're on the psoas tendon, flex your hip actively to make that tendon more prominent. And you can find it the same way on a patient. Remember the clock technique? We test the tissue by giving it a little bit of a push or stretch in all directions around the clock to see which direction is tight. For some people, pushing the tendon medial and superior is tight. Someone else, pulling the tendon inferior and lateral is tight. So whatever direction creates the tension, put the pressure on with very, very light pressure, like 2 or 3 ounces. Just a hint of tension, and hold that like a little muscle play in that region for up to 2-3 minutes. Sometimes a psoas release takes a few minutes, but it's well worth it. We're going to apply this technique with the person in a hook lying or hip flexed position. And you can consult the part 2 of the DVD and your manual to take a look at that position. The person could be side lying with their knees bent up to their chest, or supine with some pillows underneath their knees and hips to allow the knees and hips to be flexed. This gives them what's called a counter strain position, a relaxation position for the iliopsoas muscle, and will make the release much easier to handle. Make sure to measure the pain scale in the trigger points or tender points in both of these releases, pre and post release. Measure the goniometry, the range of motion of the trunk for the respiratory diaphragm, of the hip for the psoas, and you'll see some very nice changes. Don't forget to do that psoas release also for your clients with back pain. Now, after you've practiced some of the very gentle techniques, we're going to finally get to the deepest technique of the day, and that is Z friction. Z friction is a technique that I've modified from standard effleurage or longitudinal stroking and transverse friction. Just like the circular friction, we're going to be applying a stroke only in the shape of a Z in the fascial planes between the muscles and within an individual muscle. So like the circular friction, we're going to work from insertion to origin, but instead of making circles, which are more comfortable and not as deep, we're going to make a Z, a transverse motion at a 90-degree angle to the fibers, but instead of being on the fibers, we are between the fibers. Be very precise. If you don't know your anatomy, break out those books and see where those fibers lie. On palpation, you can palpate the taut bands that occur between the fibers with restrictions. So we won't be playing guitar on the fibers. We'll be doing Z's with our thumbs, our fingertips, our knuckles, and our elbow between those fibers to break the adhesions and restore normal mobility. One precaution, please. This is a very deep technique. Educate your patient that it's deep. It may feel like a deep massage, and it might be a little sore. So I like to work only within the tolerance of the patient and make sure that afterwards you use that ice as necessary or liniments, home exercise programs to manage any delayed onset muscle soreness. I don't dig deep into areas that have trigger points. I'll work around it. If you have a muscle with a great big trigger point or tender point in the middle of the belly, I'll work the origin with the circular frictions and Z's. I'll work the insertion, and I'll work all sides of the muscle and then get to that trigger point last. And when doing this, you'll find much of that trigger point has dissipated by the time you get there. Don't forget to follow the releases with some physical activity and help the person to reincorporate this motion into their everyday living. Now, you should be able to easily move between techniques from light to deep, even on an individual person. Some areas you may find you need to work deep, others you need to be very gentle because they have tender points or trigger points, or it may be a more fragile area. So use your clinical judgment, continually assess the patient to determine their needs and see what works for them. Remember to incorporate your other technologies, therapeutic modalities. Massage can warm up an area, even exercise can pre-warm the area prior to the myofascial release. And after the work, remember your neuromuscular reeducation, remember your ergonomics, posture reeducation, functional activities. Get the person back to doing what they love. Get their quality of life restored by giving them a complete program that includes myofascial release as one of its components. I'd like to mention at this time that there is a level 2 of this course. It's called Myofascial Release 2 with craniosacral therapy. In this course, we go into the 3D traction techniques of arm pull circumduction, leg pull circumduction of the body to tie the extremity tension into the trunk and pelvis. It's a wonderful way to incorporate a full body release. We also go into something called general and local listening, which is a visceral manipulation technique, feeling for changes in weight shift and balance in response to facilitating or inhibiting fascial lesions in the body. And then, of course, we go into the standard myofascial and craniosacral releases, transverse plane release, cranial base release, respiratory diaphragm, and pelvic floor. All of those are done very gently. And then finally, the cranial releases proper, frontal, temporal, parietal, occipital, sphenoid, mandibular releases are all done as part of this complete course in Introduction to Myofascial Release. So if that interests you, check out our website, www.educise.com, where you can find not only our Level 2 course, but a whole series of wonderful courses in orthopedic assessment and treatment, manual therapy, massage, and even some interesting exercise courses. I'd like to thank you very much for your attention on the video, and again, I call your attention to the reference list for further study. Good luck, and if you have any patient questions, feel free to email us at our website, and we will be happy to respond to you with whatever resources we can provide. Good luck, and God bless you.